Yesterday we have discussed about the endocrine physiology. We have reached up to this part where we have discussed all the signaling pathways for all the hormones. We have discussed how you can remember them, kind of very easily. Not very easily, but yeah, in a quite simplified way. Okay, for a cyclic AMP, you need to remember this mnemonic. Okay, and you need to write that, like every day. Then for cyclic GMP, ANP, BNP, the two things you need to remember, and the nitric oxide, of course, we have discussed that. For the IP3DAG, we have discussed that every smooth muscle constricting agent or hormone is always IP3DAG, like GnRH, TRH, ADH, which causes the vasoconstriction, oxytocin causing the smooth muscle constriction in the uterus, histamine, which is the H1 receptors that causes the bronchoconstriction, right? Angiotensin 2, gastrin. We have discussed all the steroid hormones or the fat soluble vitamins, plus the T3 and T4 thyroxine, which have the intracellular receptors. All the steroid hormones and the fat soluble vitamins and the thyroxine, they have the intracellular receptors. We have discussed about the zinc finger classes and the heat shock proteins already. We have discussed how they form the complex, which are DNA binding domain that binds to the enhancer sequence in the gene, which causes the enhancement of this transcription, and then the translation will happen. Then we have discussed about the receptor tyrosine kinase, which have the intrinsic tyrosine kinase activity that and all the growth factors that are are signaled through these type of receptors, like the insulin-like growth factor, fibrous growth factor, platelet growth factor, epidermal growth factor, TGF beta, and the insulin itself. Then we have discussed about the non-receptor tyrosine kinase, which has a JAK-STAT. Okay, the cytoplasmic tyrosine kinase is known as the JAK, which is Janus kinase. Okay, it is a cytoplasmic tyrosine kinase. Okay, whenever the hormone bind to the receptor, this cytoplasmic tyrosine kinase will become activated. Then it undergoes the JAK-STAT pathway to cause the further signaling, right? And two hormones very important: the prolactin and the growth hormone. They work through this mechanism, while other immunomodulator, all the cytokines that okay, they all work through the JAK-STAT pathway. Every blood cell like lymphocytes, erythropoietin, thrombopoietin, okay, they all work through the non-receptor tyrosine kinase pathway. We have discussed how the increase in estrogen or a decrease in estrogen can affect uh, the carrier proteins. Okay, the carrier proteins for the steroid, the carrier proteins for the thyroxine, the carrier proteins for the ions itself. Like whenever you have an increase in the estrogen, you will always have an increase in the carrier proteins, right? So the total protein value will be increased, or the hormone value will be increased, but the free hormone will be decreased. Like in case of if you have a high estrogen level, like in the OCP and the pregnancy, you have the high steroid binding globulin, okay, sex hormone binding globulin. In that case, you have a increased total level of the hormone, like in case of testosterone, but the free levels will be decreased. Okay, whenever you have an increased binding, okay, because it is a free level which decides for the negative feedback or the positive feedback, and these are the activated forms, right? The free hormones, not the bounded ones. So we have discussed up to here, and today we will discuss the pathology part. And the first is the SIADH, which is the syndrome of inappropriate antidiuretic hormone secretion. The syndrome of inappropriate ADH secretion. Okay, and if you have an excess of the ADH, then what's going to happen? It will stimulates the V1 or the V2 receptors in the renal, V1 or the V2 receptors in the kidney, in the collecting duct.
V1.
V1.
V2 in the collecting duct,
V2.
V1 in the...
Exactly.
V2.
Don't forget this thing, V2 in the collecting ducts and V1 in the vessels, right? So by activating the V2 receptors in the collecting duct, it will causes the excessive free water retention. Okay, but when you have an excess of the free water retention, what's gonna happen? You will have the inhibition of the aldosterone pathway, right? The RAS will be inhibited, and as a result, the water loss will occur through there, right? And along with the water loss, the sodium loss will also occur. Okay. Now, first thing, you have a free water retention. Second thing, you are having a loss of sodium, right? So ultimately, what you will get is the hyponatremia. Okay, but it would be a euvolumic hyponatremia. Okay, you won't get any edema, You won't get any jugular vein distension. The total body volume will be normal, but you have the just hyponatremia. Why euvolemic? Because the RAS system will be inhibited, which causes the loss of uh, sodium and the water. And above that, you also have the ANP and BNP. And remember, whenever you have a stretch in the muscle of the cardiac tissue, what's going to happen? You will have the release of ANP and BNP, right? And because of release of the ANP and BNP, what's going to happen? They will cause the natriuresis. So because of the ANP, BNP, and because of the RAS, you will have the euvolemia. So you will just get the hyponatremia. Okay. And a very important thing that you must remember that the urine osmolality, this must be equal to the serum osmolality. Very important, because you have an excessive loss of sodium and a retention of water. Ultimately, the urine osmolality will be higher than the serum osmolality. Generally, they are quite equal to each other. Okay, like 300 and 298, for example. But in this scenario, you will get a very high increase in the urine osmolality and a very low, like 100 or 120 near, right? This serum osmolality. So whenever you get that kind of a scenario, that means it is a SIADH. Okay. So discuss the aldosterone and the NP-BNP that causes the euvolemia. Okay. Now, if you have a very low sodium levels, what's gonna happen? Due to the low sodium levels, the water will be rushed inside the cells, inside the neurons. Okay, and that can lead to a cerebral edema. Okay, so you will get the neurological symptoms. Okay, like the seizures, like the lethargy, like the drowsiness, headache, nausea, vomiting. Right? These are all the symptoms of hyponatremia. Okay, and you need to correct them very slowly. Let me turn that off. Okay, so and you need to correct very slowly this hyponatremia, because if you do it very very aggressively, then in that case it can lead to the osmotic demyelination. Very important. If you correct this hyponatremia very rapidly or very aggressively, okay, then it can lead to the osmotic demyelination syndrome, which is also known as the central pontine myelinolysis. Okay, we will discuss that later in the neurology section, in which you have the paralysis of all the limbs. Only the eye part will be working. The patient can see, the patient can feel, but he just cannot move. Okay, all the four limbs will be paralyzed in this syndrome. So whenever you get a patient with hyponatremia, you need to correct it very slowly. Okay, if you do that very rapidly or very aggressively, that can lead to the osmotic demyelination syndrome. Okay, that's very important. Now, the causes of the SIADH, it includes first the ectopic ADH secretion that can happen in case of any tumor, like say the small cell lung cancer, very important. Okay, at the end will discuss the the every scenario, okay, or every disease which can happen along with this small cell lung cancer. So just remember, okay, as we go through, first is the ADH and other disease that we have discussed, if anyone remember, that are associated with the small cell lung cancer, other syndromes.
Lambert-Eaton.
Lambert-Eaton syndrome we have discussed, yes. Okay.
And hypercalcemia.
Yes. Hypercalcemia, and that's not because of small cell lung cancer, but because of squamous cell carcinoma of lung, right?
And
So,
increase ACTH.
okay, yes, go, and that will come later. Don't worry. So up to here, we will know about this ADH. We will know about the Lambert-Eaton syndrome. Okay, so just keep a list of everything. Okay, so small cell lung cancer that can cause the ectopic ADH secretion. Okay, in case of a CNS disorder or any head trauma, a very important thing, whenever you encounter a patient with any kind of head trauma, okay, in a classical step 1 question, okay, they either can cause the SIADH or it can either cause a diabetes insipidus. Because of the trauma, the patient can have a SIADH or the patient can have a diabetes insipidus. You just need to look at the serum osmolality and the sodium levels. Okay, so CNS disorders or any head trauma or any kind of a surgery, okay, and say the example subarachnoid hemorrhage, they can cause a damage to the hypothalamus and the pituitary, and that can lead to the SIADH. Okay, the pulmonary diseases like the TB, pneumonia, they can also cause the SIADH. Okay, the drugs, very important, Carbamazepine is the most important one. Okay, must remember thing. Other drugs include the SSRIs and the cyclophosphamide. The carbamazepine is the most important one that can cause the SIADH. So what are the treatment? Because you have and because you already have the excess fluid, okay, you want to restrict the fluids. First thing. Second thing, because you have the hyponatremia, you need the salt tablets, okay, or you can give the patient hypertonic saline. And this is the most important treatment. You will give the hypertonic saline, okay, and you do that very slowly. Please remember, otherwise it can lead to the osmotic demyelination syndrome. Okay, diuretics can be given. Okay, ADH antagonists like the tolvaptan, the covivaptan, okay, and the damiclocycle. These three drugs can also be given, which are antagonists to the ADH. Okay,
How
very important.
rapid uh, uh, correction of the hyponatremia causes osmotic demyelination?
See what happens because of the hyponatremia, all the water is already rushed inside the cells, right?
Hmm.
Now, if you do that very rapidly, then you know what's gonna happen. If I annotate it, this is your neuron or a cell body of the neuron, right? And all the water is rushed inside it, okay? And because of the hyponatremia, all the osmolytes which are present in this cell, they will be leaked out, right, to maintain the osmotic gradient, okay?
Hmm.
Now, all the osmolytes will be leaked out, and the free water is already rushed in, and it causes a cell swelling. Okay. Now, if you causes the hypernatremia or you correct this hypernatremia very rapidly, then what gonna happen? All of the water which was inside this cell, it will be out of the cell. Okay.
Hmm.
Exocytosis will occur and it can cause a cell shrinkage. Okay. And it happens very rapidly that cell can never be attached to it, right? And that can lead to the death of the neuron.
All
And
right. Thank
especially this thing happened with the myelin cells, like the Schwann cells and the
you.
oligodendrocyte cells. So that can lead to a central pontine demyelination or the myelolysis. Okay. That's why. Don't worry, we'll encounter this fact later again in the neurology section. Okay, so we have discussed the SIADH. We have discussed the cause of the SIADH. We have discussed the features of the SIADH. Why the euvolemia? Okay, and the second important thing is the urine osmolality will be higher than the serum osmolality. We have discussed if you want to treat the condition, you do that very slowly, otherwise you will get the osmotic demyelination syndrome. Treatments will be the fluid restriction, hypertonic saline, diuretics, ADH, antagonist.
And euvolemia is due to hyponatremia is due to decreased RAS system, right?
Yeah, exactly. You need the RAS to maintain the sodium levels, right? And because of high ANP, VNP also, you will get a natriuresis.
Right.
So now comes the diabetes insipidus, which is opposite to that of SIADH. In SIADH, you were having the fluid retention. In case of diabetes insipidus, you are having the fluid loss. The free water loss is happening, right? And it can either due to deficiency of the hormone itself, the ADH, or it can happen by any kind of mutation or a blockage in the receptors for the ADH, right? So it could be either a central, okay, and the etiology for the central one includes any tumor in the pituitary gland which can damage the parenchyma of the pituitary. That can lead to a central diabetes insipidus. Any autoimmune condition can lead to that, like, for example, sarcoidosis. If you have the neurosarcoidosis, that can damage the pituitary, okay. In case of any trauma, okay, so trauma, either it can cause the SIADH or same trauma can cause the diabetes insipidus also. Surgery can cause it, okay. Ischemic encephalopathy, which can damage your pituitary, it can cause it. Or most of the time, it would be the idiopathic also, okay. Now, this trauma also depends if you're having a transient diabetes insipidus or you are having a permanent type. In case of a hypothalamus damage, you are having a permanent diabetes insipidus. In case of a pituitary damage, okay, you will have a transient diabetes insipidus because once the pituitary is damaged, the hypothalamus will take over the functions of the pituitary gland, okay, and more specifically the posterior pituitary gland, okay. And now hypothalamus will be start secreting these hormones instead of the pituitary. So in case of any pituitary damage, you will get a transient central diabetes insipidus. In case of hypothalamus damage, you will get a permanent diabetes insipidus, okay. Findings, you will have a low levels of ADH, of course. And if you do the and for the labs, you will get a very low urine specific gravity because you're having too much free water in it, okay. Urine osmolarity will be less than 300. Serum osmolarity will be higher than 300, okay. So in as like you say, in case of SIADH, you're having a high urine osmolality and a low serum osmolality, right? But in that case, in case of diabetes insipidus, you are having a high serum osmolality and the low urine osmolality. Okay, and you also get a hyperosmotic volume contraction, because whenever you have a hyperosmolality there, the water which is inside the cell, it will be, it will rush out of the cell, right? It will cause cell shrinkage. So when you do the water deprivation test, okay, what's going to happen? Even after the water deprivation, the urine osmolality will not rise. Very important. Even after the water deprivation test, if you restrict the water, then your urine osmolality must be rising in case of dehydration, right? But in this scenario, because ADH is not working, because ADH is not there at the first place, what's going to happen? You will still have a very low urine osmolality even after the water deprivation. Okay, and as soon as you give the patient ADH analog, very important, as soon as you give the patient ADH analog, the urine osmolality will be increased, and that means that ADH wasn't there at the first place. Okay, so a 50% rise in the urine osmolality only after the administration of ADH analog will be a very specific test for it. The treatment will include the analogs of the ADH, that includes the desmopressin. Okay, and the second thing you will do is the hydration, of course. Okay, in case of nephrogenic diabetes insipidus, you are having either the mutations in the receptors or you are having some kind of a toxin which is blocking the receptors. Okay, the causes includes the hereditary, which is for the ADH receptor mutation. Secondary causes includes the hypercalcemia. We have discussed how the hypercalcemia can lead to the to diabetes insipidus. Similarly, for the hypokalemia, you can have it. Lithium can block the receptors directly, and that can cause an nephrogenic diabetes insipidus. Dimethylcycline and all these agents like the tolvaptan and the conivaptan, they can cause the nephrogenic diabetes insipidus. Okay, so ADH antagonists, lithium, hypokalemia, hypercalcemia, and the hereditary. These are the causes of nephrogenic diabetes insipidus. Lab findings will be similar to that of central diabetes insipidus. Okay, but you have a normal ADH levels. Rest all findings will be same. Okay, and once you do the water deprivation test, what's gonna happen? Am I not audible?
It is fine.
Yeah, audible.
Okay. Okay. So where were we? Yeah. For the water deprivation test, if you restrict the water, then in a normal individual, the urine osmolality must be rising because the water must be reabsorbing to maintain the hydration. In case you are having a nephrogenic diabetes insipidus, you won't be having the function of a functionable ADH, and as a result, even after a water restriction, you will have a very low urine osmolality, right? And even if you give the patient ADH analog like a desmopressin, it won't increase the urine osmolality. Very important. Even if you give the patient desmopressin, because the receptors are already blocked, okay, this analog won't be work, right? So as a result, even if you give the patient desmopressin, it won't increase the urine osmolality, and that is a characteristic test for the nephrogenic diabetes insipidus. The treatment includes the thiazide diuretics, the indomethacin can do that, okay, hydration, of course, and the dietary salt restriction. Very important, and you must avoid the offending agent also. Okay. So this is your water deprivation test, which is no water intake for 3 to 4 hours or 2 to 3 hours. Okay, and then you check the osmolality of the urine and osmolality of the serum. Okay, and after the 3 to 4 hours, you will give the patient ADH analog and check for the serum osmolality and the urine osmolality. If the serum osmolality is decreasing and urine osmolality is increasing, that means the test is okay. If the serum osmolality is still very high and urine osmolality is very much low again, that means it is a thing, right? A problem with that. So what are the symptoms of the central diabetes insipidus? There will be polyuria, the polydipsia, okay, and excessive thirst would be there. The patient will have a frequent drinks of water, okay, very important. And due to this water intake also, the patient can get the further loss of sodium sometimes, okay, very important. I think yeah, that would be all about the central and the nephrogenic diabetes insipidus. Any doubt?
No.
Can you explain mechanism of hydrochlorothiazides in nephrogenic diabetes insipidus?
See, what happened when you give the patient thiazide diuretics, the patient will be having diuresis, right? And because of the diuresis, the PCT will get activated too much that will start absorbing the water. Initially, the PCT will be absorbing, I think, 70% of the water, 70 or 80%, right? It will reach to 99% when you give the patient thiazides. Okay, that's why it would be helpful to give the patient thiazides in case of diabetes insipidus. Because once the diuresis happen, the PCT will become activated and it will cause a further, reabsorption of the water. That's why.
Okay, thank you.
What's the use of indomethacin?
NSAIDs, I really don't know why the NSAIDs are given, but yeah, it is kind of a treatment.
Okay.
Um,
That amyloid is also osmotic diuretic, so it's also work. Which way could you please explain?
yeah, yes. Okay, then comes the pituitary. We have discussed the posterior pituitary. Now comes the anterior pituitary. Okay, and first the under secretion of the hormone. What are the causes of the under secretion? And whenever you get the under secretion, you will get the low growth hormone, you will get the low TSH, right? You will get the low GnRH, you will get other low hormones, right? So symptoms will be similar to that. You will get the short stature, you will get the amenorrhea, you will get the hypogonadism, loss of libido, you will get the hypothyroidism, right? And all these symptoms will occur. Okay, and the treatment will be to give the patient replacement therapy, hormone replacement therapies. Okay, important thing on this paragraph is the causes. Okay, first thing is the non-secreting type pituitary adenoma. If you have a dysfunctional type pituitary adenoma, then it will destroy the parenchyma of the pituitary, right? And when the parenchyma of the pituitary is destroyed, it won't be releasing any hormone, right? So you will get the hypopituitarism. The kinopharyngioma, which is most commonly seen in the children's. Okay, this can cause the hyperpituitarism. Can anyone remember from which structure this tumor arises?
Rathke's pouch.
Rathke's pouch, yes. And which layer? Ectoderm, endoderm, or medullum?
Ectoderm.
Endoderm.
Pharynx.
Ecto, yes. Oral ectoderm. Okay, please remember that. Then comes the Sheehan syndrome. See what happens during the pregnancy. Okay, and because of the estrogen, okay, the female will have a high levels of this prolactin, right? In order to get the high levels of prolactin, all the cells which are secreting the prolactin, they will be hyperproliferating under the influence of estrogen, right? And when they do the hyperproliferation, okay, what's going to happen? The blood supply must be increased to the pituitary. But what happens ultimately? Actually, see, the cells are hyperproliferating, but not these blood vessels. Okay, so there would be a tension between the blood supply and the use of the oxygen. So it is something like a supply demand mismatch. Okay, so in case of pregnancy, there is already a supply demand mismatch in case of pituitary, right? And when the patient get a postpartum hemorrhage, like say, okay, or any kind of a blood loss after the pregnancy or during the pregnancy, then in that case, the necrosis or the ischemia of the pituitary gland will happen, right? And because of this necrosis and the ischemia, the patient will get the Sheehan syndrome. Okay, so because of the estrogen during the pregnancy, hyperproliferation of the lactotrophs will occur. Okay, but the blood supply is not adequate. Okay, so there will be a tension between the oxygen supply and the oxygen demand. Okay, supply demand mismatch was there. And above that, if the patient get the postpartum bleeding or any loss of blood during the pregnancy or after the pregnancy, the patient will get the infarction or the necrosis of the pituitary, and she will get the Sheehan syndrome. Okay, so it is a pregnancy-induced pituitary growth that makes the pituitary very susceptible to the hypoperfusion. Okay, and whenever the patient gets a postpartum bleeding, it will lead to the ischemia or necrosis. Okay, so the prolactin won't be releasing anymore now because of necrosis, and as a result, the lactation will be stopped. Okay, the patient will also have a loss of menstruation, cold intolerance because of the hyponatremia. Okay, hypocortisolism will occur, or the ACTH will be lost completely. Okay, nausea vagara will happen, headache will also happen, right? So these are all the symptoms of Sheehan syndrome. So it would be a patient who is a female, and after the postpartum period, Okay, she won't be she won't be having any lactation, right? And above that, she will be having this a loss of hairs. Okay, headache will be there, cold intolerance would be there, and that's how you immediately know that this must be a case of Sheehan syndrome. Above that, they can also give you a history of anemia in the patient. Okay, and for that, they can tell you about this hemoglobin count. The hemoglobin count will be less than 10, like 9 or 8. So that's how you know that there must be a bleeding loss occur. Okay, and that's why the hemoglobin count is low. So just look for the hints. Okay, very important. Then comes the empty cellar syndrome. It is because the atrophy or the compression of the pituitary, okay, due to some kind of increase in the pressure in the sella trasica. Okay, generally it happens with the idiopathic intracranial hypertension. Okay, also known as the pseudotumor cerebri, pseudomotor cerebri, right? Idiopathic intracranial hypertension, which is most common in the obese women. Okay, and because of a high pressure, the pituitary will be compromised or it will get atrophied, and as a result it can lead to the empty sella syndrome. When you do the CT or the MRI of the patient, you won't get to see the pituitary of the patient, and that's how you know that this must be a case of empty sella syndrome. Then comes the pituitary apoplexy, which generally happens in the pituitary tumors. Okay, and why? Whenever you have a tumor, along with the tumor, you also have the angiogenesis, right? And whenever these blood vessels are formed, these new blood vessels are very fragile, very weak, very leaky, right? So when the hemorrhage happens in the pituitary gland, that can lead to the damage of the pituitary gland suddenly. Okay, and this is known as the pituitary apoplexy. Generally happens with the pituitary adenoma. Okay, it will present as a sudden onset of the severe headache and the visual impairment. Why? Because the optic chiasm is just above the pituitary gland. Because of the hemorrhage, this optic chiasm can be it can be compromised or can be compressed, right? And that can lead to the bitemporal hemianopia. Okay, and you will also get the KLF3 palsy because of the hemorrhage. So we'll get the diplopia also. Okay, and above that you will get the features of hypopituitarism. So whenever you encounter a patient with headache, first thing with headache, and second thing with the bitemporal hemianopia, that means it must be a case of pituitary adenoma. Okay, and once the pituitary adenoma is there, the blood vessels inside the tumor can get ruptured and can lead to the pituitary apoplexy. Okay, any brain injury, any kind of hemorrhage can damage the pituitary gland. Okay, radiation can cause a fibrosis in the pituitary gland. Okay, you also have the neurosarcoidosis, which can damage the stalk of the hypothalamus in the pituitary, or it can damage the pituitary directly, right? Then also you can have the hypopituitarism. Okay, and remember one thing, that hypothalamus, always has a positive feedback on the pituitary hormones, but one hormone is under the negative feedback, which is the prolactin. So whenever you get a damage of the pituitary stalk, every hormone will fall. Okay, the levels of every hormone will be falling, but the levels of prolactin will be rising because of loss of dopamine inhibition. Okay, then you also have a Kalman syndrome, which you will study later in the reproductive section. The Kalman syndrome, you will have a loss of GnRH in them. Okay, so we'll have a loss of GnRH, loss of LH, loss of FSH, hypogonadism will be occur, loss of secondary sexual characteristics will occur, and the patient will also get the anosmia. Okay, very important. So these are all the causes of the hyperpituitarism. Remember that. Symptoms are very easy to remember. Okay, hypothyroidism, hypoparathyroidism will occur, right? And the loss of GnRH will occur, nausea will occur. Okay, and yeah, that would be all. Any doubt on that part?
I'm having one confusion.
Yes.
In Sheehan syndrome, we are having absent menstruation. So
Yes.
the cause of absent menstruation can be due to that, like after pregnancy, after gestation, there's a 6 month of absent menstruation. So the
That would be
reason,
physiological normal. That would be physiological. But in that case, you are having a loss of pituitary. That means loss of GnRH, right? Loss of GnRH, loss of estrogen, loss of LH, loss of FSH. And because of all these things, the patient can never, the cycles of the patient will never be normal again, right? All the cycles will be absent, even after 6, 7, or 1 years. Okay.
okay,
There won't be any return of the symptom or any cycle, right? So this is a Sheehan syndrome. Normally, you will have the return back of cycles after 6 months or 7 months, right?
Yeah.
But in case of Sheehan syndrome, even after 1 year, 2 year, or 3 year, the cycles won't be returned back, right?
Yeah. Okay. Thank you.
Okay. Then comes the acromegaly, okay, which happened because of excess growth hormone secretion. Very important. It happens because of the excess growth hormone secretion. See, you guys must remember the pathways for the this growth hormone signaling, okay, and the pathway for the for signaling of the IGF-1 and other things, okay. So if the step 1 asks you, okay, that what kind of proteins or what kind of enzymes will be elevated in case of acromegaly, in the tumors of the pituitary in case of acromegaly, so they will be asking about the signaling pathway for the GHRH. Okay, you guys know that hypothalamus will release the growth hormone, regulatory hormone, that will stimulate the pituitary to release the growth hormone, right? So there must be a mutation in any of the pathway which is for the GHRH, right? And does anyone remember the GHRH pathway? Which type of signaling will be there? Cyclic GMP, cyclic AMP, receptor tyrosine kinase. What kind of the signaling would be there?
CAMP.
CAMP, yes. So in all of these cells, in the tumor of the acromegaly, in the tumor of the pituitary, which is causing the acromegaly, there would be a high cyclic AMP levels, right? And because of this high cyclic AMP level, that this tumor would be secreting the growth hormone. And this is a very important thing. Okay, step 1 can try to confuse you with these facts. Okay, so if they ask you about the tumor, which enzyme is high in the tumor, elevated in the tumor, this would be the cyclic AMP. If they ask you which enzyme would be elevated in the cells which are under the growth hormone influence, then these would be the JAK-STAT pathway. Okay, so make sure you got it right. Okay, now, so the acromegaly is because of the excessive growth hormone secretions. Okay, and it generally occur only in the adults. Okay, in case of children, it would be the gigantism. Okay, in case of children, it would be the gigantism. In case of adults, it would be the acromegaly. Okay, so what are the findings of the acromegaly? First, you will get a very large tongue. Okay, you will have a large organ size. Every organ in your body will be increased. Okay, so large tongue with deep furrows would be there. Deepening of the voice would be there. Okay, the size of the hands and the feet will be increased. Okay, you will get the pain in the hands and feet also, right? The coarsening of the facial features will occur, as you can see. This is a coarsening of the facial features. Okay, frontal bossing is very important, would be there, right? And because of this growth hormone, you will get the excessive growth, excessive high metabolism. You will get the diphoriasis, excessive sweating would be there. Okay, diabetes mellitus will be occurring in these patients because of this insulin resistance. Okay, and you will also get the hypertension in the patients, right? And there will be an increased risk of colorectal polyps because the growth is occurring everywhere, right? So you will have an increased risk of this colorectal polyps, and it can lead to the cancer. And if the step 1 asks you that what is the cause of death, it would be the cardiomyopathy. Okay, and like I told you, the organ size of every organ in the body will be increasing, and so that the heart, in the heart you will find the left ventricular hypertrophy. Okay, and because of that, the patient will get the ventricular tachycardia, and that can lead to the death. So organomegaly, the cardiomyopathy, facial features, the prognathism, okay, frontal bossing, okay, arthritis will be there. Carpal tunnel syndrome, why? Because the size of hands and feet, the bones will be increasing, which can compress the medial bone, and that can lead to the carpal tunnel syndrome. Very important, acromegaly is a very important cause of the carpal tunnel syndrome. When we discuss the MSK chapter, we will discuss all the causes of the carpal tunnel syndrome, and one of the causes is the acromegaly. And one other important cause we have discussed already in the general pathology. Anyone remember?
Amyloidosis.
Amyloidosis, yes. Okay, do remember these causes. Okay, at the end it would be very helpful for you to remember. Okay, so any doubt on the acromegaly so far about these findings?
I have one question.
Yes.
In acromegaly, it's written that it's typically caused by pituitary adenoma, but you've
Yes.
said that it's mainly due to increase in GHRH.
No. I said all the signaling pathway. See, the signaling pathway of the GHRH include a cyclic AMP, right?
Yes.
It is because of a mutation in the cyclic AMP, which is causing the hyperactivation of the cyclic AMP. Okay, because its growth hormone can only be released whenever the cyclic AMP is there, right? Without cyclic AMP, growth hormone won't be released.
Okay.
It is not because of high. It can be because of high GHRH, of course, right? But
Yeah.
in case of adenoma, you are having a mutation in the cyclic AMP pathway. Okay, and because of that mutation, you are having an excessive secretion of the growth hormone.
Okay, got it. And because of that, we are having an increased size in pituitary.
Yeah,
Right?
yeah, exactly.
Okay, got it. Thank you.
Now, for a diagnosis, of course, you will have a high serum IGF-1 levels. And does anyone remember where this IGF is secreted?
Liver.
Liver, exactly. So do remember the location. Okay. And even if you do the patient this glucose test, okay, this glucose will fail to suppress the growth hormone, because you guys remember that hyperglycemia can suppress the growth hormone, right? So even if you give the patient glucose, it won't suppress the growth hormone. This is a test, right? And second thing, you can do the MRI of the pituitary gland. You will see the enlarged pituitary gland in case of in this MRI. Okay, so it would be a diagnosis. For the treatment, you guys remember the octreotide, which is a somatostatin analog. It will inhibit the growth hormone. And what other hormone will be inhibited by the octreotide?
All the hormones except dopamine, prolactin.
Okay. Yeah, but the important ones, which FA has mentioned, I mean, every hormone will be inhibited, no doubt. But the important ones that you must remember,
Glucagon and insulin.
that's not in the pituitary, it's in the GI. Not in the GI, of course, but not in the pituitary, not in the brain. In the pituitary, where you actually use octreotide to suppress these hormones.
Can you repeat the question?
See, in the very start of the physiology, we have discussed about the somatostatins, that it decreases majorly two hormones, right? So that we use the octreotide in case of any brain disorder, in case of any pituitary hormone dysregulation. We use the octreotide majorly in two areas only. Okay, one is the acromegaly. Okay, second one is the TSH. Okay, don't forget that. Growth, this somatostatin or the octreotide mainly inhibit two hormones. One is a growth hormone, second is the thyroid stimulating hormone. Okay, and so in these two diseases, okay, in case of
Yeah.
hyperthyroidism and in case of acromegaly, we mainly uses the octreotide. Okay, not in any other tumor.
Yes.
Okay, mainly for these two tumors or these two conditions, we can use the octreotide. Okay, then we have this agent, the paclitaxel, okay, which is for the GH receptor antagonist. You can use that also. Okay, dopamine agonist, cabergoline can be used. Okay, and sure, I think that's great. If they ask you about the findings other than these symptoms, it would be a activation of the osteoblasts. Okay, it would be increased collagen synthesis. It would be decreased deposition. So we'll get the linear bone growth. Okay, in case of IGF-1. Okay, that would be what heart failure can happen, ventricular tachycardias can happen, and that can lead to the death of the patient. Okay. In children, you will get the gigantism. And does anyone remember the difference between the growth hormone and the estrogen in case of this bone stimulation?
Growth hormone causes the linear growth, whereas estrogen causes the fusion of the epiphyseal gland.
Yeah, initially it will cause a growth, but at the same time,
Growth.
along with the growth, it will be causing the fusion also. So initially, the patient will have a very large height, but at the end of the puberty, they would be short statured. Okay, and this is the difference between gigantism and the hyperestrogenism. Okay, any doubt on the on this acromegaly?
No.
Then comes the hyper and the hypothyroidism. If you guys remember the function of the thyroid gland, you can easily know the difference between the hyper and the hypothyroidism. For the metabolic, we know that it will activate the sodium potassium pump. Okay, so the function of the thyroid hormone is to activate your metabolic system, to increase the metabolic rate, right? In case of hypothyroidism, the metabolism will be decreased. So what you will get is a cold intolerance. Okay, first thing. Second thing, the sweating will be lost. Even if you do the exercise, you will get a very minimal sweating. Okay, because of this low metabolic rate, you will get a weight gain. Very important, right? And if you guys remember, the action of the this thyroid on the kidney, so it can cause the hyponatremia, right? Because of the decrease in the free water clearance. Very important. Okay, very important. So the cold intolerance, sweating loss, okay, weight gain, and hyponatremia. These are the findings in the hypothyroidism in case of metabolism. For the skin, okay, it can cause a dry skin because of loss of sweating. Okay, it will cause the cool skin because of cold this thing. Okay, and the blood flow will be lost also. So cool and dry skin, right? You will get the coarse and the brittle hair, as you can see in the figure. Okay, sorry, nails, the brittle nails, as you can see, you will get the brittle hair. Okay, you will get the hair loss. Okay, thyroid hormone actually support the hair growth. So in case of hypothyroidism, you will having hair loss. Okay, you will get a very thin hair. Okay, then you also get the puffy face, which is due to the edema. If you guys remember, okay, this thyroid function is to remove the edema from the body, right? So it can cause the edema also, and which is a generalized non-pitting type edema, also known as the mixed edema, right? Because of the glycosaminoglycan depositions. Very important, glycosaminoglycans. The function of the thyroid gland is to clear these glycosaminoglycans. Okay. If the glycosaminoglycans won't be cleared, they will draw out the water, and that can cause the non-pitting type edema. Okay. So yeah, so the cool and the dry skin, because of the loss of this beta stimulation, you will get a decrease in the blood flow, right? You will get a dry in the cool skin. Okay, also because of this cold thing and loss of sweating, you will get a dry skin, right? You will get the brittle nails, you will get the brittle hairs. Okay, you will get the loss of hairs, alopecia, right? You will get the edema because of the increase in the glycosaminoglycans, which increases the osmotic pressure in the interstitial space, and that can cause the water retention and the edema, which is a mixed edema, right? Very important. And for symptoms, you will also get the thinning of outer 1/3 of the eyebrows, because the hairs everywhere on your body, they will be started getting thin, right? And because of thinning of the hair, you will get the thinning of the outer 1/3 of the eyebrows, right? You will also get a thinning of the hairs on your head. You will get the alopecia. For the ocular, because of deposition of the glycosaminoglycans, you will get the periorbital edema. Swelling would be seen around the eyes. Okay, very important. Then for the GI tract, okay, because you guys know that it will activate the thyroid gland, or the thyroxine hormone will stimulate the GI tract. Okay, it can cause a diarrhea. So in case of hypothyroidism, the constipation is the most common symptom of the hypothyroidism. Very important. Uh, this weight gain, loss of sweating, edema, and the constipation. These are the 4 most common symptoms of the hypothyroidism. Okay, because of loss of this metabolic rate, you will also get a loss of appetite. Okay, for the musculoskeletal, you will get the hypothyroid myopathy. Okay, which is the proximal weakness of the muscles. You will get the high creatine kinase. Very important. You will get the high creatine kinase because of the muscle damage. You will get the proximal weakness. Okay, so patient generally this complains of the loss of overhead movement of the hands. Okay, and like the combing or like sitting up from the chair, okay, the patient will become very weak. Okay, so proximal weakness would be there. Okay, which is a difficulty in the combing, difficulty getting you know sitting up on the chair, right? And the patient will also get the high creatine kinase. This is very important. Okay, because of the deposition of these glycosaminoglycans, okay, they will be deposited, they will cause the edema, and that can compress the median nerve, can cause the carpal tunnel syndrome. So hypothyroidism is another important cause of the carpal tunnel syndrome. You will also get the myoedema, the edema in the muscles. Okay, and for that, whenever you do the percussion on any group of muscle, Okay, so you will get the focal muscle contraction. Okay, so how they will explain you the myodema in the step 1, it would be a patient. Okay, and on the hand of the patient, when you do the percussion at any sign, at any site, okay, the focal muscle contraction will occur. Okay, and a small lump is formed. Okay, focal muscle contraction and a small lump will be formed. Okay, whenever you try to percussion or stuck with a hammer. Okay, the patient will also have a delayed relaxation of the hand. Okay, so whenever they handshake, they will have difficulty to release the hand. Okay, whenever they touches the doorknob, they will be having difficulty to release the hand after that. Okay, because of the delayed relaxation. Okay, very important. Patient will also get the exercise intolerance, cramping would be there, myalgia would be there, muscle pain will happen. Okay, does anyone remember any other condition or any other disease in which you are having a delayed relaxation of the reflexes? Difficulty and in releasing the hand from the handshake or after the doorknob touching?
Myotonic dystrophy.
Yes. Okay, do remember these things, which is because of the protein known as, or the enzyme known as
Dystrophin.
no, not a dystrophin, myotin protein kinase.
Okay.
Okay, and what kind of disorder it is? Autosomal dominant, autosomal recessive, or X-linked?
X-linked.
Yes. Okay, do remember these things. So for the reproductive, you will have a loss, you will have a disruption in the cycles. Okay, so the patient will get the amenorrhea. Okay, or the patient can get the abnormal uterine bleedings. Okay, loss of libido will be there, infertility will be happens, right? And because you know that whenever you get the hypothyroidism, whether it is a primary one or whether it is a secondary one, you will always have a high TRH levels, and these high TRH levels can cause the increased release of prolactin. So hyperprolactinemia is also a symptom of the hypothyroidism. Okay, for the neuropsychiatric, very important. For the neuropsychiatric, you will always get a depression. So whenever you get a patient with a history of depression, you always do the test for the thyroid. Okay, to ensure that this medical condition is not because of any hormone disbalance. Okay, whenever you encounter any patient with a depression, okay, you have to look in the question stem for the thyroid hormone levels. Okay, if they didn't mention that, if you didn't run the test, then you will consider that the patient is having a hypothyroidism if other symptoms are also present. Okay, I got similar questions in which they didn't mention anything about the hypothyroidism and they asked me what could be the cause of the patient. Okay, so this would be the hypothyroidism, not the real depression. Okay, very important. So hypothyroidism is a known cause of depression. For the cardiovascular, because the beta stimulation is lost, the patient will get the bradycardia and the dyspnea on the exertion because of loss of cardiac output. Okay. For the labs, she will first get the increase in the TSS. This TSS test is very important. Okay, you won't do the T3 or the T4 test. First, you have to do the TSS because it is very sensitive. Even even if you have a normal T3, T4 count, okay, in case of a hypothyroidism, even if you have a normal T3 and T4 count, you will have an increased TSH. Okay, very important. So this test is very sensitive. T3 and T4 will be decreased in the later stages only. At the very initial of the stage, at the very initial of the hypothyroidism, you won't get the T3 and T4 decrease, and that's why TSH is a very sensitive test. Okay, and if you guys remember, this thyroid hormone will also causes the increase in the LDL receptor expression, right? So because of this hypothyroidism, you will have a loss of LDL receptor expression that can cause the hypercholesterolemia. This is very important. I encountered, I think, 2 or 3 questions in UWorld and emboss on that. Okay, so a very important fact that and they will ask you why this hypercholesterolemia is occurring in case of hypothyroidism. It is because of the decrease in the LDL receptor expression. Okay, very important. Then similarly, opposite to that, you will get the hyperthyroidism, you will get the heat intolerance, you will get the excessive sweating, you will get the weight loss. Okay, you will get the high activity of sodium potassium pumps. Okay, opposite to a dry skin, you will get the warm skin. Okay, moist skin because of the sweating, you will get the moist skin, of course, and And because of the vasodilation also, you will get a very fine hair, okay? And you will get the paratibial mixed edema only in case of Graves' disease. In case of hyperthyroidism, you won't get any mixed edema, okay? But it is a very specific for the Graves' disease, that in case of Graves' disease, although it is a hyperthyroidism condition, you will get the paratibial mixed edema because of stimulation of the fibroblast cells and the stimulation of adipocytes. We will study that later, okay? So it would be a thickening of the skin over the shins, and it is a non-pitting type edema. Step 1 can also ask you this fact, whether it is a pitting edema or the non-pitting edema. So it is a non-pitting type edema. Okay. For the ophthalmopathy in the Graves' disease, okay, you will get the periorbital edema, you will get the exophthalmos, and it is very specific for the Graves' disease only. Okay. You will get the leg retraction, which is very increase in the sympathetic stimulation of the levator papilla superior and the superior tarsal muscle. For the GI, you will get the diarrhea just opposite to the constipation. You will get the diarrhea and you will get the increase in the appetite. Okay. Patient can get a this thyrotoxic myopathy, okay, in which you have a normal CK but a weakness. So see, weakness is there in both the diseases, okay. But if you have an increase this CK levels, that means it is a hypothyroidism. If the CK levels are normal, that means it is a hypothyroidism. And if you guys remember, at a very at a very low concentration or normal concentration, okay, this thyroid hormone actually promotes the bone growth, right? It will cause the formation of the bone, but at a very high level, it actually activates the osteoclast cells, right? And by activating the osteoclast cells, it will causing a increase in the calcium levels, okay? And when the calcium level is increased, what's going to happen? The kidneys will be starting excreting the calcium too much, right? And the patient will get a normal calcium level ultimately. So in case of this hyperthyroidism, you will get a normal calcium levels along with the bone resorption. It is very important. Step 1 will ask you this lab things. Okay, in case of hyperthyroidism, you will get a bone resorption, weakness in the bone or the osteoporosis along with the normal calcium level. Okay, and PTH will also be decreased. So because of this loss of PTH and increase in the renal excretion of calcium, you will get a normocalcemia. Okay, along with the osteoporosis. For the reproductive, yeah.
Dr. Chole, can you repeat this
Yes.
point again a bit slowly?
Oh, okay. So we were up to this musculoskeletal part, right? We have discussed the osteoporosis. Okay. This T3 or the T4, because T4 will be activating into the T3 again. So they will cause a direct stimulation of the bone resorption. They will be direct stimulating the osteoclast cells, right? And because of direct stimulation of the osteoclast cells, the patient will get the osteoporosis. But the calcium levels will be absolutely normal because of loss of this parathyroid hormone. Okay. And the bone resorption will be first started in the cortical bone. See, you have the two part of the bone, okay, the cortex and the medullary portion, okay, and the resorption will be start in the cortical bone. So you will get the subperiosteal thinning and the cystic degeneration in the bone. You will get some cystic spaces when you do the X-ray of the bone. You will see some hollow spaces in the bones, okay. So this is the subperiosteal thinning in case of osteoporosis. For the reproductive, same as the hypothyroidism, you will have the abnormal uterine bleeding or the amenorrhea. You will have the infertility. You will have the loss of libido. Okay, very important. Then for the neuropsychiatric conditions, just opposite to the hypothyroidism, in which you are getting a depression, in case of hyperthyroidism, you will getting the anxiety. And these anxiety is because of the beta receptor activity. You guys remember that, this thyroid hormone who causes symptoms because of the beta receptors, right? So you will get the anxiety, you will get the fine tremors, you will get the chest pounding, okay, because of the high beta receptor activity, okay. Opposite to the hypothyroidism, in which you are having a delayed reflexes or decreased reflexes, in case of hyperthyroidism, you will having a high reflexes or the briskness in the reflexes. Hyperreflexia you will get ultimately, right? For the CVS, opposite to that of hypothyroidism, you were getting the tachycardia, palpitations, dyspneas, and arrhythmias, and most commonly the atrial fibrillation in case of hyperthyroidism. Okay, because the metabolic demand of the heart is increased, you will get the chest pain. Okay. Systolic hypertension would be there because of high beta adrenergic receptor activity. Okay, you'll get a very high cardiac output, and when you have a high cardiac output, you will have a high systolic blood pressure, right? So you will get a systolic hypertension. Okay, very important. So for the labs, okay, the most common test that you perform is the TSS test. Okay, you will have a low level of thyroid stimulating hormone, even though in case you are having a T3 and T4 normal along with the hyperthyroidism, okay, TSH will be decreased because it is very sensitive marker. Okay, the change in the TSH will be very sensitive. So even though if you have a normal T3 T4 count, the TSH will be changed in very early stage, right? So the checking for the TSH is very important. Okay, and opposite to that of hypothyroidism, you will get a increased LDL receptor expression in case of hyperthyroidism. So we'll get a low LDL level, low HDL level, and low total cholesterol. Very important. Okay.
Dr. Chaudhary, I have two questions.
Yes.
Why is it that the parathyroid hormone will be decreased in hyperthyroidism?
Because the function of the parathyroid hormone is to maintain the calcium levels, right, in the blood. In case of osteoporosis, in case of hyperthyroidism, because of the bone resorption is increased, the calcium level will be rising in the blood. And when the calcium levels are already rising, then the PTH must be suppressed, right?
Okay, so that causes the normal calcium because that balances out.
Yes, exactly.
Okay. And then one more question is in hypothyroidism. Can you explain like how you get hyponatremia due to decreased free water clearance?
Function of the the function of the thyroid gland is to increase the water excretion from the kidney. Okay, so if that won't happen, that can lead to the hyponatremia, of course, and that is another cause of the edema also.
Okay, okay. Thank you.
Because of the free water clearance. Okay, the free water must be lost from the kidneys whenever the thyroid is there. But when the thyroid is not there, the free water will be retention. Okay, the retention of the free water will occur, and that can lead to the hyponatremia. It's all because of the free water. Free water is just a water, okay, nothing and no electrolyte. Okay, just the water.
Thank you.
I have one question.
Yeah, do ask.
Is there any reason why we find those reproductive symptoms in hypo and hyperthyroidism?
See, thyroid, has this influence on on every symptom, or sorry, on every system of your body. Okay, it has influence or on any system of your body, including the reproductive system. So whenever you have a dysregulation in these hormones, they will ultimately cause the dysregulation in the other system also, like the GI system, like the reproductive system, like the CVS system. Okay, that's why.
Okay, thank you.
And
Yes,
like
sir.
you guys told, yeah, do ask.
I had one thing. When you say cystic degeneration, does that mean like you kind of like you get bubbles of degeneration like you see in multiple myeloma, or that it collapses inwards?
See, because of the bone resorption, spaces will be created inside the bone, right?
So that's going to be like an even degeneration, right?
Yeah, kind of.
Okay.
And the similar thing you can also get in case of chronic kidney disease, because in that case, you will having a high PTH levels, right? And that high PTH level, similar to that of hyperthyroidism, that will cause the bone resorption, right? And the bone resorption will occur in the cortex part first. So similar to that of similar to this this thyroidism, you will also get the cystic spaces in case of this chronic kidney disease. So because of the bone resorption, the calcium will be removed, the collagen will be removed, and you will left with the cystic spaces. And that you can easily see on the X-rays as a very dark lesions, hollow spaces. Okay.
So you're saying that in chronic kidney disease, since I would not be able to have effectual parathyroid hormone, the same cystic degeneration will show.
Yeah, I'm having a high PTH level in that case.
A high PTH level wouldn't that increase my calcium? So my calcium you're saying would be coming from the bone, and that's what would
Yeah,
be.
exactly. From the bones, the calcium will be coming into the serum, right, in the blood. So bones will be resorpting. Okay, cystic spaces will be creating inside the bone.
Okay, so and my second question is the mood swings for hyperthyroidism, is that more of like the calcium coming out, or is that more of a like the beta sympathetic hyperactive state?
What thing?
Why do we have
Why do we have?
mood swings?
Oh, mood change because of this.
Yeah.
First is a cycle change. Okay, like I told you, whenever the hyper or hypothyroidism is there, the cycles will be kind of dysregulated, right? So this
You're
can cause
talking
a mood
about
swing.
menstrual cycles, right?
Yes.
You're talking about the menstrual cycles?
Yes, exactly. Because of GnRH and the FSH and LH interference, this can cause the cycle changes, the loss of libido, infertility, and other things. Okay, and because of that, you can have the mood swings also.
Okay,
sometimes the patient will have a normal mood, and sometimes there will be this angry thing. Okay, and sometimes a very anxiety will occur to the patient. Okay.
Yes, sir. Thank you.
Any more doubt on this page?
No, thank you.
And one important thing that you must know is this ADST in the thyroid resistance, a special type. Okay, whenever you have any thyroid resistance, doesn't matter if the TSH is normal or low, okay, or high, the T3 or T4 is low, normal or high, doesn't matter. Okay, if you have a thyroid resistance, okay, then it can always leads to the ADST in children. Very important. Okay, generally it occurs because of the inherited mutations in the receptors of the TSH and the thyroids. Okay, not TSH but the thyroids. Okay, so the patient will have a high level of the T3 and T4. First thing, the patient will have a high level of T3 and T4, but because the receptors of the T3 and T4 are now mutated, they will never give the negative feedback to the pituitary, right? And the patient will also have a high TSH. Okay, so as you can see, you can get a high TSH in the hypothyroidism, right? Whenever I say I am having a high TSH, that means I'm talking about the hypothyroidism, right? But this is not the case here. The patient is not having hyperthyroidism, but the patient is having a kind of hypothyroidism, right? And along with this high TSH. And the symptoms can mimic both the hyperthyroidism as well as the hypothyroidism. Like I said, it doesn't matter if you're having the symptoms of hyperthyroidism or the hypothyroidism. If you encounter a patient, a children who is having a ADST along with this high level of T3, T4 and high TSH, all three things are raising. Okay, and the symptoms would be of this hyperthyroidism, let's say. Okay, so that means it can be ADST, and it must be a case of thyroid resistance only. So step 1 will list you some options like hypothyroidism, hyperthyroidism, okay, the loss of TS or something like that. You will always neglect this option and you will choose always this option, the thyroid resistance. So whenever you encounter a children with high this TSH, high T3 and high T4 along with ADST, that means thyroid resistance. A very special case it is. Okay. Any doubt on that?
No, thank you.
And another important thing is the euthyroid 6 syndrome. So whenever you have any kind of infection in the body or any kind of inflammation because of the cytokines release, okay, these cytokines will suppress the 5-deiodinase enzyme. Okay, and because of this and because of the inhibition of this enzyme, the peripheral conversion of the T4 to T3 won't occur. Okay, and as a result, the patient will get a in the early stages, the patient will get the low T3, the T3 count and the normal TSH and the T4 count. Very important, the euthyroid 6 syndrome at a very initial stage because of the inhibition of the enzyme by the cytokines, by the glucocorticoids. Okay, you will get the loss of conversion of the T4 to T3. So you will get a low T3 count and normal TS and the T4 count. At a very late stages, okay, you will get the low T3, low T4 and the low TSH. So this is known as the euthyroid 6 syndrome. So they will give you a patient with a recent history of any kind of illness, okay, or a hospitalized patient, okay, and they will ask you what would be the labs of this patient. Okay, so they are asking about the T3, T4, and the TSH levels. Okay, or second thing they can ask you about, they will give you these labs, they will give you the low T3 count, the normal TSH and the normal T4, and they will ask you what will be the reason behind it. So it will be the inflammatory cytokines which are inhibiting the enzyme 5-deiodinase. Okay, so this is also very important, the euthyroid 6 syndrome, because of the inflammation. So we have discussed the symptoms of the hypo and the hyperthyroidism. Okay, we have discussed the lab reports of the hypo and the hyperthyroidism. Now we're going to discuss the causes of the hypo and the hyperthyroidism. First is the hypothyroidism. Okay, and the first and the most important cause, or the most common cause, is the Hashimoto thyroiditis, which is an autoimmune condition. Okay, generally happen in the iodine sufficient regions. Okay, which means the United States, of course. Okay, so the most common cause of hypothyroidism in the United States is the Hashimoto thyroiditis. It is an autoimmune condition in which the antibodies are formed against the thyroid peroxidase, which is the enzyme which is responsible for the oxidation step, okay, for the organification step, and for the coupling step. So all these three steps are inhibited, and as a result, what you get is a loss of T3, T4, right? So because of this anti-thyroid peroxidase antibody, and you also get the anti-thyroglobulin antibodies, which are the antibodies against the thyroglobulin, which is the colloid in the thyroid follicles. If you guys remember, the colloid in the thyroid follicles is known as the thyroglobulin. Okay, and it is under a direct influence of the TSH. So whenever you have a high TSH, you will have high colloid. Whenever you have low TSH, you will have low colloid, right? And the antibodies will be formed in case of Hashimoto thyroiditis. These conditions are associated with the HLA-DR3 and HLA-DR5. Those individuals which are having HLA-DR3 and this HLA-DR5 in their genes, they are very likely to get this Hashimoto thyroiditis. Okay, and because the B cells will be there. Whenever you do the biopsy of the patient, what you will see is the lymphoid aggregates with the germinal centers. And you guys already know that B lymphocytes will form the germinal centers so that they can release the antibody, right, after becoming the plasma cells. Okay, so whenever you do the histology, what you will see is the lymphoid aggregate. You will get the lymphoid cells along with the germinal centers. And as you can see, because B lymphocytes are involved, and it is a chronic inflammation, because all of the autoimmune conditions are the chronic inflammations, and a high chance will be and a very high, the complication of a chronic inflammation is to become the cancer, right? So it can lead to the non-Hodgkin lymphoma, which is of type B cell lymphoma. Okay, very important. And if I say very specifically, that it means it is a marginal B cell lymphoma, very important. So in case of Hashimoto thyroiditis, if they ask you about the complication, so it would be the marginal B cell lymphoma. Okay, and also along with these germinal centers, you will get the Hurtle cells. These are the Hurtle cells. Okay, very important. And yeah, and these Hurtle cells actually representing the metaplastic change in the thyroid follicles. Okay, these Hurtle cells are actually the metaplastic changes in the epithelium of the thyroid glands or the thyroid follicles. Okay, very important. So Hurtle cells and the germinal centers, two things. And because of the germinal centers, you can also get the marginal B cell lymphoma. Okay, findings would be a non-tender thyroid, very important. It would be a non-tender thyroid. It would be moderately enlarged. Why? Because you're having a hyperthyroidism, and because of this hypothyroidism, you're having a high TSH. Whenever you have a high TSH, you will have an increased size of the gland. Okay, so an increased size in the gland, it would be a neck swelling like thing. You will see a neck swelling. Okay, and this enlarged gland along with the non-tender is very important. Okay, so any doubt on this Hashimoto thyroiditis?
No.
Okay, the second cause is the postpartum thyroiditis, very important. It is always self-limiting, and it must happen within 1 year after the delivery. Okay, the patient will be first to present as a transient hyperthyroidism. Okay, and after the hyperthyroidism, the patient will get the hypothyroidism. A classical case would be a female patient who just delivered a baby. Okay, and within 1 year, the patient started developing the symptoms of the hyperthyroidism. Okay, and after some time, when this hyperthyroidism symptoms are over, the patient will get the hypothyroidism. Why this hyperthyroidism occurring? Is it because of the inflammation? And because of the inflammation, the cell will be destructing. Okay, the membrane of the cells will be damaging, and as a result, all of the hormones will be releasing out of the glands. All of the stored, the T3 and T4 will be releasing out of the glands, and that's why you get the hyperthyroidism. And once all of the hormones will be released out, the patient will get the hypothyroidism. Okay, very important. And yeah, usually the thyroid is also painless, okay, normal size, and sometimes also mildly or diffusely enlarged. Mild diffusely enlarged because of hypothyroidism, patient will get a high TSH, so they can have a large size of the thyroid gland. Lymphocytic infiltrates would be there, very important. Okay, and yeah, occasionally you can also get the germinal center formation. So the histology will be similar to that of Hashimoto thyroiditis, very important. Histology will be similar to that of Hashimoto thyroiditis. So whenever you encounter a case where the histology of the patient is given along with the germinal centers, you can think about the Hashimoto thyroiditis and the postpartum thyroiditis. Along with the formation of the germinal centers, the patient is also having the symptoms of hyperthyroidism. Okay, that means it is a case of postpartum thyroiditis. And of course, the patient will also have a history of recent delivery. Okay, so all of these things will make you choose the postpartum thyroiditis. So please remember, histology will be same as that of Hashimoto thyroiditis. Okay, but in that case, the patient will get the hyperthyroidism first. Okay, and the patient will also having a history of recent delivery or recent pregnancy. Okay, so yeah, that would be all. Any doubt in postpartum thyroiditis?
Both Hashimoto and postpartum will be having early stages hypothyroidism, because in Hashimoto also it's certain that there may be hypothyroidism early in course.
No, in Hashimoto you will have a hypo only. At least that was the study.
Okay, because
Sometimes hyper can occur, no doubt. But whenever the patient present to, it is always a case of hypo.
Okay.
The symptoms will be very milder, so they generally don't report in case of hyperthyroidism stages. They generally report only when the hypo is occurring, right? So for the Hashimoto in exam especially, you only get the hypo. Okay, and in case of postpartum thyroiditis in exam, you will first get the hyper, must hai ye to, okay, and then you will get the hypo. So for the exam, you can remember Hashimoto always hypo, and for the postpartum, it is always hyper and then hypo. But in real life, you can get the hyperthyroidism case, no doubt, but it is very early in the disease. Okay, and almost every time when the patient present to, there will be most time the hypothyroidism symptoms only.
Okay, got it. Thank you.
Okay, then comes the congenital hypothyroidism, and the most important question Stanford will ask you that why you give the patient levothyroxine or any enzyme replacement therapy in case of congenital hypothyroidism. Okay, and this is to prevent the early neurological dysfunction. Very important. You want to give the patient therapies for the hypothyroidism to the infant because you want to prevent the neurological symptoms dysfunction. Okay, because you know that this thyroid hormone is very much responsible for the brain development, for the brain maturation, right? So this is a very feared complication. Okay, so it could be an antibody mediated maternal hypothyroidism if the pregnant female is having a history of this Hashimoto thyroiditis. Okay, then it can deliver these antibodies to the baby also, to the fetus also, because they can easily cross the placenta being IgG type. Okay, so the baby or the fetus can also get the congenital hypothyroidism. It would be a case of thyroid dysgenesis, very important, and this is the most common condition. Okay, and and it could be the agenesis, it could be the ectopy, it could be the hypoplasia. So in that case, you will having a very low level of TSH, low level of T3, and low level of T4, right? And the fetus can also get this hypothyroidism by the iodine deficiency. And for the iodine deficiency, you must remember the patient will always be an immigrant patient. Okay, for this iodine deficiency, the patient must be having a immigrant status. Okay, very important. And if the enzyme mutation occur, which is a thyroid peroxidase, then then the baby can also get the hypothyroidism, and this is known as the dysharmogenetic goiter. Very important. Okay, so what are the findings? Initially, up to the 6 months, the baby will be absolutely normal. Why? Because after the 6 months, the mother will be providing the T3 and T4 through the placenta. Okay, so after the pregnancy, up to the 6 months, the level of this T3 and T4 will be normal. Okay, only after 3 or 4 or 5 months later, the patient will be started developing the symptoms. Okay, and the first symptom would be the constipation. Okay, after the constipation, patient can develop the this protruding umbilicus. Okay, which is the umbilical hernia. Very important. It will be a bulge over the umbilicus. Okay, like that. It would be a bulge over the umbilicus. Okay, you will compress this hernia, it will go down, it will be reduced. Okay, and when you release your hand, it will again go up. Right, this is the umbilical hernia. So constipation will be the first symptom. The patient will be having this umbilical hernia. Okay, then patient also starting having the non-pitting tape edema. Okay, and they will call it a puffy face child. Okay, edema of the face. Okay, and the patient will also get the poor brain development. Okay, patient will get the poor brain development, and this is the most feared complication of this hypothyroidism, and that's why you need to give the patient drug as soon as possible, right? And apart from these things, you can also have a enlarged tongue. Patient can also have a enlarged tongue. So lethargy would be there, because of course you won't be having energy much. Lethargy would be there. Enlarged frontal will be there. Poor feeding would be there. Dry skin would be there. Jaundice would be there. Okay. Non-preventive edema would be there. Okay. Umbilical hernia would be there. Constipation would be there. Okay. And these are all the symptoms of congenital hypothyroidism. Okay. Causes are most important. Okay. In case if you are having an anti-thyroid antibody in the plasma of the fetus, you can check this. You can check the plasma for these antibodies, also for the IgG antibodies. Okay, and in that case, you will be having a high TSH count. Okay, low T3 count and a low T4 count. They can ask you the labs on this antibody mediated maternal hypothyroidism. Okay, high TSH, low T3, and low T4. Okay, and you will also have a enlarged gland. Okay, but in case of thyroid dysgenesis, you will have a very small gland or a atrophied gland. Okay, because of agenesis. Okay, so yeah, that would be all about the cretinism or the congenital hypothyroidism. Any doubt on that?
No.
Okay, then comes the subacute granulomatous thyroiditis. As the name suggests, it is a granulomatous inflammation. So whenever you do the biopsy of the patient, in case of subacute granulomatous thyroiditis, you will see the granulomas. Okay, and because it is an inflammatory condition, a granulomatous inflammation, it would be always painful. Okay, so first thing is the painful. Okay, second thing is that granuloma. Okay, it is generally occur just after a flu. Whenever a patient got any viral infection, okay, any upper respiratory tract infection, or any viral infection, the patient can get the subacute granulomatous thyroiditis. Okay, it is always hyperthyroid in the early stages. Because of restriction of the parenchyma, you will have the release of all the hormones. Then the patient will get the hypothyroidism. Okay, so high level of thyroglobulins would be detected in the plasma. Very important, the test, you will detect the high level of thyroglobulin. Okay, and if you have a high level of thyroglobulin in the plasma, it suggests that the patient is having a destruction of the tissue, of the thyroid tissue, right? ESR will be high, which shows the inflammation is there. Jaw pain would be there, and a very tender thyroid is present. Okay, so whenever you get a patient with a history of recent illness, any viral illness, even a cough and a runny nose could be helped. Okay, a recent fever history, and now the patient is having a very pain in the neck. Okay, the patient will be having a granulomatous inflammation, very high ESR, jaw pain. Okay, and symptoms of hyperthyroidism along with high thyroglobulin levels. That means it is a case of subacute granulomatous thyroiditis. Any doubt on this part? Any doubt?
No, sir.
Okay. Then comes the Riedl's thyroiditis or the Riedl thyroiditis. Okay. In this scenario, you are having the replacement of the normal parenchyma of the thyroid with the fibrous tissue. Okay. And the inflammatory infiltrate. Okay. So you're having an inflammatory infiltrate along with the fibrous tissue. All of the parenchyma of the thyroid will be replacing by this fibrous tissue. Okay. And the fibrosis even may extend to the local structures like the trachea and the esophagus. So you can get the dysphagia sometimes. You can also get the respiratory distress along with the symptoms of hypothyroidism. Okay. And it can mimic the anaplastic carcinoma. Okay. You will see that later in the tumor part of the thyroid glands, anaplastic tumor, which are very aggressive, that they may also involve the structures like the esophagus and the trachea. So symptoms can mimic the anaplastic carcinoma. Okay, but when you do the biopsy, what you will see is the fibrosis everywhere. The collagen deposition would be there everywhere, and that's how you know this is a case of Riedl's thyroiditis. And when you palpate the thyroid gland, it will be very hard, just like a rock. Okay, so it would be a fixed hard rock-like thyroid. Okay, on the palpation. Okay, and it would be a painless goiter. Okay, symptoms of hypothyroidism would be there, and when you do the biopsy, you will see the fibrosis and the collagen deposition. It is generally associated with the IgG4 related systemic diseases. Okay, it is not very much important to remember. Just remember the fact that the thyroid would be very hard rock-like. It would be painless. Hypothyroidism and the fibrosis will be there. Okay. Then comes the other causes which are generally seen in the underdeveloping countries. Okay, and mostly in the cases of this immigrant status of the patient. That first one is the iodine deficiency. Okay, so whenever you want to choose any option with the iodine deficiency, you need to make sure that the patient is having the immigrant status. Okay, because the normal deficiency of the iodine in the United States is very rare. Okay, so it is always going to be a case of immigrant, right? Then other drugs like the amiodarone, if you guys remember from the CVS, okay, the amiodarone you have to check for the PFT, TFT, and LFT. Okay, so TFT because amiodarone can cause the hypothyroidism. Okay, lithium can cause either the hyperthyroidism or it can also cause the hypothyroidism. Okay, Wolff-Chaikoff defect, if anyone remember, what is Wolff-Chaikoff defect?
Increased iodine inhibit the iodine intake.
Yeah, exactly. When you take the too much iodine in the diet, it will inhibit the thyroid peroxidase, and as a result, when the enzyme is inhibited, you will have a hypothyroidism. Okay, so iodine deficiency only suspect in the immigrants, not in the US patients. So,
Dr. Chaudhary, I have a question.
yeah,
So
do ask.
amiodarone is about 30% iodine, right?
What?
So the amiodarone contains iodine. It's made up of like
Yes,
30%
yes,
iodine. So
yes.
can that cause hypothyroidism?
Yeah, absolutely, of course.
Okay, because you said that amiodarone can only cause hypothyroidism.
Yes, amiodarone can only cause the hypothyroidism, not the hyper. Lithium can cause both hyper as well as hypo.
But since amiodarone contains iodine, can it cause hyperthyroidism as well?
See the Wolff-Chaikoff effect. If you have too much iodine, it can inhibit. Okay, if you have
Okay.
too much iodine, it can actually inhibit these enzymes. Okay, so you will get the hypothyroidism also. Okay,
Okay. Okay. Thanks.
so for the amiodarone, mostly the hypo only, not hyper. For the lithium, it would be both hyper as well as hypo. Okay, so these are the puffy faces. As you can see, the edema of the face, the edema of the eye. Okay, and yeah, I think that's. You can also see the inflammatory infiltrate in case of this histology diagram, this histology figure, and it is representing the renal thyroiditis. Okay, and this is the swelling or the enlargement of the thyroid gland, which is also known as the goiter. Okay,
Sir, what
yeah, yeah, do ask.
is your D? What are we
Yes.
looking for, like the like the blue dots for the neutrophils, or is there any other thing that we should be looking for in that picture?
In D,
In D.
see all this collagen surrounding. This is all the collagen. Okay, and these blue dots are the inflammatory cells. Okay, and you can also see the giant cells in it. Okay, and like I told you, giant cells are the marker of the inflammation, right? Whenever you have the inflammation, you can have the giant cells. Yes. So giant cells, inflammatory cells, and all of the pinkish material that you are seeing here. Okay, this pinkish material is all the collagen. Okay, and why collagen? Because of the fibrosis, right? So a
Yeah.
diffuse pink area, like in the waves, as you can see, all of this in the waves, right? And this is all the collagen. Okay, and that's why, because of the collagen deposition, you are having the fibrosis. So the fibrosis, along with the inflammation with some giant cells, that means it is a Riddle's thyroiditis. Okay. Okay, then comes the hyperthyroidism, and the most common type is the Graves' disease. In the Graves' disease, you are having the antibodies which can mimic the TSH. Very important. In the Graves' disease, you are having antibodies which will mimic the TSH. They will bind to the TSH receptors. They will activate your thyroid gland. Okay, and they will cause the symptoms. So it is an autoimmune disorder. Okay, in which the thyroid stimulating antibodies, which are IgG type, are forming in your body, right? Very important. So they will stimulate the TSH receptors. Okay, and the TSH receptors are not only found on the thyroid gland, but these receptors are also found on the fibroblasts as well as the adipose tissue. Okay, the TSH receptors are found also on the fibroblasts and also on the adipose tissue. Okay, so first thing would be the hyperthyroidism because of the stimulation of the TSH. Okay, second thing would be the increase in the size of the gland. See, you're having the hyperthyroidism along with the increase in size of the gland. Okay, this is a Graves' disease. Okay, other thing, because of the dermal fibroblast, this stimulation, you will have the increased release of the cytokines. Okay, you will have an increased fibroblast secretions of the glycosaminoglycans. Okay, and because the glycosaminoglycans are the osmolytic agents, they will draw the water. Okay, and they will cause the muscle swelling, they will cause the eye swelling. Okay, adipose tissue will be the receptors on the adipose tissue, the TSH receptors will be stimulated, and you will get a high adipocyte count. And because of the high adipocyte count, okay, and the fibroblast secretions, you will get the exophthalmos. Both the adipocytes, okay, this adipose tissue and the fibroblast are found just behind your eyeball, right? And when you get the increased secretions from the fibroblast and you get the proliferation of the adipocytes, you will get the this exophthalmos, okay, which is an outward protrusion of the eyes. Very important. So first thing is the hyperthyroidism symptom. Second thing is the exophthalmos. Third thing would be the enlargement of the gland. And fourth thing would be, because these fibroblasts are also present in your skin, okay, the deposition of the glycosaminoglycans in the skin can cause the edema also. And most commonly, it would be the edema over the shin of your leg. Okay, it would be the edema over the shin of leg, right? And it is a non-pitting type edema. Very important, it is a non-pitting type edema. So because all of the symptoms are because of these antibodies only, okay, so the mainstream treatment would be the glucocorticoid therapies. Okay, because if you give the patient treatment for the hyperthyroidism, like the beta blockers or the PTO or other agent, they can inhibit the thyroid symptoms completely. But because these fibroblasts and the adipose tissue, they are under the response of this of these antibodies. Okay, you cannot suppress the exophthalmos. Okay, and this mixed edema in case of Graves' disease. To treat the mixed edema and to treat the exophthalmos, you need to give the patient glucocorticoids. This is a must therapy. Okay, very important. For the histology, you will get the tall and a very crowded follicular epithelial cells, and you will get the scalloping, very important. You will get the scalloping of the colloid, which is my colloid will be like that. You will get this scalloping like that in the colloid. Okay, this is a very important histological marker. Okay, whenever you see the colloid, something, because normal colloid would be very circular, right? And diffuse pink inside. Everywhere it is pink inside, right? When you do the histology, you will see like that. In case of this Graves' disease, you will get the scalloping of the colloid, and not just a single scalloping. Sometimes multiple scalloping could occur like that. Okay, this is a features of the Graves' disease. Scalloping, very important. So first thing is the activation of IgGs. Okay. Second thing is the these IgGs will stimulate the thyroid gland to cause the hyperthyroidism. Okay. Because of the TSH receptor stimulation, you will get the increase in the size of the gland. Okay. Because of the stimulation of adipocytes and the dermal fibroblast, you will get the exophthalmos and the myxedema. Okay. In order to treat these conditions, you first give the patient the therapy for the hyperthyroidism, of course. But of course, because by giving just a therapy for the hyperthyroidism, you cannot resolve the myxedema and the exophthalmos. So you need to give the patient glucocorticoids. Okay, very important. And yeah, this is all about the Graves' disease. Any doubt?
Yes, sir.
Yes.
Why is there a why do we, okay, why would we
Yeah.
get gag increase in gags in both hyperthyroidism and hypothyroidism?
See, the function of the thyroid hormones is to remove these gags. Okay. So in case of hypothyroidism, because the gags are not removing by these hormones, what gonna happen? The gag will be deposited in the skin and they will cause the edema, right? But in case of hyperthyroidism, although thyroid is there, right? But these gags will be secreting by the fibroblast, because the antibodies which are stimulating the thyroid, the same antibodies are also stimulating the fibroblasts. Okay, that's why only these fibroblasts will be secreting the gags under the influence of these IgG antibodies. If you inhibit the antibodies, the stimulation of the fibroblasts will be inhibited. You won't get the gags. Okay.
Okay.
The function of thyroid hormone is to remove the gags. Okay. But in case of Graves' disease, it's a very specific thing. Okay. Other than the Graves' disease, if you are having a hyperthyroidism, you won't get to see the gags. Okay. These gags are very specific for the Graves' disease only, along with the hyperthyroidism. Okay. So a case of hyperthyroidism along with the edema in the body must be a case of Graves' disease, a very specific combination. Okay.
Okay. And so we in hypothyroidism, we're getting gags because we have the water
Low
balance.
thyroid.
Because
Because we have low thyroid.
so you aren't able to remove the gags.
Exactly.
And here you have too many. Okay, thank you.
Yeah. See, mixed edema is a very characteristic feature of the hypothyroidism, right? But mixed edema along with hyperthyroidism is a very characteristic feature of Graves' disease. Okay.
Okay.
Step 1 will ask you this thing. Step 1 will give you a history of a patient with hyperthyroidism. Okay. Or they will specifically tell you that this disease is a Graves' disease, and they will ask you what is more, what is the most specific thing about this Graves' disease which is not present in any other hyperthyroidism disorder. So this would be the mixed edema, and they will list you down the option like the non-pitting. Sorry, I just give me a second. So yeah, step 1 will give you a history of a patient with a Graves' disease, and they will tell you that this is a Graves' disease, and then they will ask you what is the most specific thing about this Graves' disease which make it very special to as compared to other hyperthyroidism disorders. Okay, and that would be the non-pitting type edema over the shins. Okay, which is the mixed edema, right? It is very specific for the Graves' disease in case of hyperthyroidism. Must remember that. Okay.
Thanks.
Now, then comes the toxic multinodular goiter, in which what happening, some of the follicular cells, they become self-active. Okay. They work, they started working independent of the TSH. Whether TSH is there or not, okay, they will be working. And because they are working, they will be releasing the T3 and T4. And that's how they can cause the multinodular, the toxic goiter and the symptoms of hyperthyroidism. Because some of the follicles, they become self-active. Okay, and they started working independent of the TSH. Okay, and because they started working independent of the TSH, they will be releasing the T3 and the T4. And what you will get is the hyperthyroidism. And please remember the name the multinodular. That means you have a multiple nodules in the thyroid, and this thing will help you differentiating it with the tumors. Okay, we will come to that part later on. Okay, but see, multinodular one are always rarely malignant. Okay, they do not have any malignant potential if they are multinodular. But if they have any single nodule only, that means it is a tumor. Okay, a very important distinguishing the point. Okay, then comes the thyroid storm, and the thyroid storm is all because of the beta receptors. You will get the fever, you will get the diarrhea, you will get a tachycardia, you will get the anxiety, you will get the diphoriasis, you will get the agitation, you will get a delirium. Okay, and most of the symptoms are due to the beta receptors. So whenever you have a hyperthyroid storm, okay, whenever you have a acute hyperthyroidism symptoms, okay, the first thing you will give the patient is the beta blockers, so that the beta receptors could be inhibited and the patient will return and the symptoms will be suppressed. After giving the patient beta blockers, because first thing they were blocking the receptors, and second thing they will be inhibiting the peripheral conversion of T4 to T3. Okay, that's why the beta blocker therapies are very effective. Second thing will be to give the patient propylthiouracil. Okay, and after giving this drug, it will inhibit the thyroid peroxidase enzyme, and second thing, it will also inhibit the 5-deiodinase, so that the peripheral conversion of the T4 to T3 can also be inhibited. Okay, the corticosteroids can also be given to inhibit any kind of inflammation. Okay, potassium iodide, very important. The Lugol iodine, it is also very important. Like I said, the Wills-Charcot effect. Okay, if you give the patient too much of the iodine, the T4 will be inhibited. Okay, so you give the patient Lugol iodine, the potassium iodide, whenever you have the thyroid storm. Okay, so it is generally a complication which occurs in a patient who are having a previous history of the hyperthyroidism and they are under the therapy, but somehow they stopped the drug. Okay, or they didn't complete their courses, so they're suddenly having these symptoms of the hyperthyroidism, or along with the history of hyperthyroidism, even if they're taking a drug, they will get the infection or some kind of a trauma, some kind of a surgery. Then this thyroid storm can occur. Okay, symptoms: agitation, delirium, fever, diarrhea, coma, tachycardia, diphoriasis, anxiety, tremors. Okay, most symptoms are due to the beta receptors. So first thing would be to give the patient is the beta blockers. Any doubt on the thyroid storm? Any doubt on thyroid storm?
No, sir. Thank you.
Okay, then comes, yeah.
Increase LFT because overload or decrease function of liver?
Increase LFT because of?
Yeah, because of overload.
Because of overload.
What is the reason here for LFT increasing?
What is the reason of the LFT? Inflammation is there, right? Some amount of inflammation is always there. That's why giving the patient these steroids, right?
Yeah.
That's why inflammation would be there. That will cause the LFT rise. Okay, hepatitis can also occur in case of thyroid storm. And like I said, this thyroid will be, every system in your body under the influence of the thyroid, right? So whenever you have a dysregulation in the thyroid, every system can be disrupted. Okay, so one of them will be the GIT also, and a little bit of the inflammation will also be there in case of thyroid storm, so we'll get the high LFTs, and that's why you give the patient steroids to inhibit the inflammation. And these steroids can also inhibit the peripheral conversion of the T4 to T3. Okay, so 3 drugs which can inhibit the peripheral conversion of the T4 to T3. First are the beta blocker, second are the PTU, and third are the corticosteroids. Okay, remember these facts. And like I said, because you have the infection, right? Whenever you have an infection, whenever you have a trauma, whenever you have a surgery, okay, in these conditions, you can have a thyroid storm, right? So they also contribute to the high LFTs because of the inflammation in the body. Okay.
Yeah. Okay. Thank you.
Okay. Then comes the Jod-Basedow phenomena, which is opposite to that of Wolff-Chakoff defect. In the this defect, in the Wolff-Chakoff effect, what's gonna happen if you give the patient iodine? The release and the formation of T3 and T4 is inhibited. While in jot-based phenomena, what's gonna happen if you give the patient iodine, hyperthyroidism will occur. Okay, and it only seen in the patients which are having the immigrant status. Okay, in the patients who are having a very prolonged history of the iodine deficiency. So whenever a patient who was iodine deficient come into a state of iodine, iodine sufficient stages, okay, like any patient who is recently migrated to the United States, okay, so when they came into the United States, they can be entered into the iodine rich states, okay, or sometimes it can happen after the IV contrast use, because most of the IV contrast that you use for the CT or the MRI, they contain the iodine in them. Okay, they contain the iodine in them. Again, if you give the patient amiodarone, because this amiodarone also has the iodine in them. Okay, so whenever a patient with the iodine deficiency suddenly comes into the iodine sufficient state, okay, what's gonna happen? They will have a very increased release of T3 and T4. Okay, and that can lead to the jot-based phenomena, hyperthyroidism. Okay, autonomous nodules will be formed. Okay, so you will get the jot-based phenomena. Okay, so it would be the hyperthyroidism following the administration of any iodine. Okay, it could be a patient who is having a recent history of immigration. Okay, and when they enter the United States, they eat food there and they will become this hyperthyroid. Okay, it could be a patient who is having a history of immigrant. Okay, and they're undergoing some kind of CT or MRI. Okay, with the contrast use. Okay, so they can get the hyperthyroidism. Okay, yeah, I think
Dr.
that would be all.
Chaudhary,
Yeah.
quick question. So in this case, you have amiodarone causing hyperthyroidism.
Yes,
So,
because it
so
has iodine.
okay, so amiodarone can cause both hypo and hyperthyroidism then?
See, it depends on the scenario. If the and like I told you, in case of only immigrant, when the patient previously having a history of when the patient is having a history of iodine deficiency, only then it can cause the this
Okay.
hyperthyroidism. In the normal patient, okay, which most often is the the patients in the United States, it will cause the hypo only, and it is only specific phenomena, only one phenomena where you get the hyperthyroidism. Okay.
Okay, okay, thank you.
Yeah, so please remember the immigrant status is must. Yes. You're asking something? Okay. So any doubt on this jot-based phenomena, which is opposite to that of the Chekhov defect? Now?
What can you repeat can you please tell about the duration, like you have written 2 to 12 weeks following iodine exposure?
Yeah.
I don't
Yeah.
get that thing.
Once you get the iodine exposure, like after a CT or after the MRI or after the immigration, okay, it would be 2 to 12 week after the immigration or 2 to 12 week after the IV contrast or the amiodarone use, you will get the hyperthyroidism only. Okay, 2 to 12 week exposure is must. Okay.
Okay, 2 to 12 week continuous exposure, right?
No, one
Or
exposure
just
only is enough. One exposure is enough.
okay, and
Okay.
it will create autonomous thyroid tissue.
Yeah, exactly. So a patient who
Oh,
is immigrant, he entered the United States, and after 2 to 12 weeks later, he started developing the hyperthyroidism symptoms. Or it could be a patient who is having a history of immigrant. Okay, he did some CT or MRI with the contrast, and after CT or MRI, 2 to 12 weeks later, he developed the hyperthyroidism. That means it is a jot-based phenomenon. Only one exposure is enough. Okay.
okay, okay. Thank you.
Is this previous thyroid cell only start secreting these thyroid hormones, or there will be separate autonomous nodules will form?
So repeat again, please.
These autonomous nodules will be formed with this thyroid gland only, like because of feedback, right?
Sorry, I didn't understand.
I mean, how these nodules will form, like what is the, like where and how it works? Like
The toxic multinodular goiter, remember, you have an independent
okay.
working nodules, right? Similar to that, you will get these nodules in the jot-based phenomena. Once you get the iodine, some of the nodules will become active. Okay, they won't be responding to any TSH. They won't be responding to any negative feedback. They just secreting the TSH. They just secreting the T3 and T4 without any enter influence. Okay.
It is specific for those who is migrated, like
Yeah,
immigrant.
exactly. Because most of the iron deficiency will get only in the migrants, right?
Yeah.
Deficiency of iodine is very much less common in the United States. So that's why in the step one, okay, it is almost always a case of immigrant only. Okay. Okay, then comes the cause of goiter. You have two types. Okay, one is the diffuse type and second is the nodular type. Okay, every cause that we have studied for the hypothyroidism, okay, in every cause we will get the high TSH level, and that's why a diffuse enlargement of the thyroid gland. Okay, first thing. Second thing, we have also discussed that in case of in case of the Graves' disease, because you are having a TSH stimulatory antibodies, you will get the diffuse enlargement of the thyroid gland. Okay, in case of iodine deficiency, you are having a low T3 T4 count, you are having a high TSH count, you can get the diffuse enlargement of the thyroid gland. If you're having a TSH secreting pituitary adenoma, okay, the TSH will be stimulating the thyroid gland to cause the diffuse enlargement, right? So in all these conditions, you're having a diffuse enlargement, right? But in some other conditions, you can also have a nodular enlargement in which one of the two lobes of the thyroid, okay, will become nodular. Some part of one lobe will become nodular, okay, and at rest, all other part would be absolutely normal. Okay, so the first thing would be a toxic multinodular goiter in which you get the multiple nodules. Okay, if you get a patient who is having a history of hyperthyroidism, okay, along with that, the patient is having a multiple nodules in the thyroid. Okay, it could be unilateral, it could be bilateral. That means the patient is having a toxic multinodular thyroid, right, or the goiter. Second thing will be the thyroid adenoma and the thyroid cancer. In case of thyroid adenoma and thyroid cancer, only one nodule would be there. Okay, they will cause the unilateral nodule. Very important. And along with the unilateral nodule, in case of adenoma and in case of cancer, you won't get any hypo or hyperthyroidism symptoms. Okay. So when you got a patient with multiple nodules along with the hyperthyroidism, that means a case of toxic multinodular the goiter. Okay. But a patient who is having a unilateral solo nodule, okay, or maybe a two nodules up to, right? But no symptom of hyper or the hypothyroidism, that means it is a case of cancer. Okay. Similarly, thyroid cyst can form, okay, and thyroid cyst can appear as the nodular structure. Okay, so from here, so so up to here, any doubt? The cause of goiter, any doubt? Diffuse and nodule types.
Yeah, I have a question, Dr. Chaudhary. So
Yes.
earlier you said that when you have multiple nodules, it is
Yes.
rarely malignant, right? So if you have like a solitary nodule, then does that mean that it's mostly malignant?
Yes, exactly. Mostly malignant.
Okay, but then in thyroid adenoma, it's written benign solitary growth.
But it is, sorry, not malignant, but it's a tumor. Sorry, not malignant, but it is a tumor.
Is a tumor. Okay.
Having a single nodule means a tumor. It could be malignant, it could be non-malignant, dependent upon the histology, of course. You will do the histology, you will do the biopsy to determine that. Okay. But having a single nodule means always a cancer. Okay. It could be a benign, it could be a malignant.
And having multiple nodules means that it's malignant cancer, right?
Having multiple nodules means it is non-malignant. It is not a cancer. It is just a hyperthyroidism. Okay. Simple.
All right.
No
Right.
cancer. Multiple. Okay.
Okay, thank you.
With single, with solo nodules, it means a cancer.
Okay.
Most of the times, of course, not every time, but most of the times. And especially for the step one, they will give you these scenarios. Okay.
Okay, thanks.
Okay. Then comes the thyroid adenoma. Okay. Which is a solitary growth of the tumor of the thyroid. Okay. It is mostly non-functional, which are also known as the cold. Okay. See, And one of the important differentiation between the toxic multinodular disc goiter and the thyroid adenoma and other cancer is that these are cold and these are non-functional. So even if you give the patient iodine, okay, these cells, these follicles won't take up the iodine. But in case of toxic multinodular goiter, if you give the patient iodine, any radioactive iodine, you will see that these follicles will be taking the iodine. Okay, so if the iodine uptake is there, that means it is a working type nodule, right? If the iodine uptake is not there, that means it is a non-functional type. Okay, very important. Thyroid adenoma sometimes can also cause the symptoms of hyperthyroidism, but it is extremely rare. Okay, very important. And when you do the histology of the patient, when you do the biopsy of the patient, what you can see is the multiple colloids. Okay, as you can see here, and there's a very crowding of the colloid, a very dense areas of the colloid will be seen. Okay, normally I have so much spaces between the two colloids, but in case of cancer, because it is a rapid, because it is a, you know, the overgrowth of this follicle, so you will have a crowding of the follicles, as you can see. Okay, very important. And some of the colloids, they even overlapping each other's. Okay, so this is the histology of the thyroid adenoma. Okay, and if the tumor, it do not have any capsular invasion. Okay, if the tumor has a capsule, okay, and the invasion of capsule is not occurring, that means it is a benign tumor. If the invasion of the capsule is occurring, that means it is a malignant tumor. Okay, very important. The only differentiating factor between the thyroid adenoma and the thyroid carcinoma, okay, would be the absence of the capsular invasion. Okay, if the tumor is having this capsular invasion, that means it is a follicular carcinoma. Okay, if the tumor is not having any kind of this invasion, that means it is a case of thyroid adenoma. Step 1 will ask you this, and the only way to differentiate these two cancers is to do the biopsy of the patient. Okay, and on the biopsy, if you see like if you say this is the capsule, maybe let's say, okay, and under this capsule, if I do it like that completely, this is a capsule of a tumor, let's say, okay, and under the capsule, if the tumor is seem like invading this capsule, okay, and going out of the capsule like that, that means it is a malignant tumor. But if you do the biopsy and you get the intact capsule, you will get the intact capsule and all of the tumor is only inside this capsule part, that means it is a benign tumor or the thyroid adenoma. Okay, the only thing that will be able to differentiate, because in both the tumors you will get the crowding of these colloids. Okay, but only in the thyroid only in the follicular disc carcinoma you will get the invasion of the capsule. Any doubt on the thyroid adenoma?
No.
Okay. Then you must remember one another important thing, which is the radiation injury. Okay, which generally happen after any nuclear reactor leak. Okay, so what happens because of this nuclear reactor leak, it can leak the iodine 131. Okay, which is a radioactive part of the iodine. So what's going to happen if the iodine 131 is in the environment, it will be taken up by our cells of the thyroid gland. Okay, and that can cause the thyroid carcinoma. Okay, it can cause a radiation induced hypothyroidism and the thyroid carcinoma. To prevent this condition, you always give the patient glucose iodine. Very important to prevent this condition, to prevent the cancer because of the radioactive leak. Okay, first thing you give the patient is the glucose iodine. Okay, in the glucose iodine, because you're giving the iodine, which is a normal one, it will compete with the this iodine 131 for the uptake by the thyroid gland, and as a result, all of the thyroid gland will be saturated by the iodine, not the iodine 131. Okay, and as a result, you can prevent the cancer because of this iodine 131. So very important, Stephen will ask you whenever you have a nuclear reactor leak, you have a I-31, you will give the patient glucose iodine as a treatment. They can ask you about the treatment, or they can ask you why you are giving the patient glucose iodine. It is because of a competitive binding on the receptors for the receptor intake. Okay, very important. So, any doubt?
No, thank you.
You guys can also ask me why I am not giving patient thyroid peroxidase inhibitors at first place. Because if I give the patient these inhibitors, then they will also inhibit the uptake of the iodine, right? So why I'm not giving the patient anti-thyroid medications? Anyone?
Patient will develop symptoms of hypothyroidism.
Well, that's going to happen if you give the patient glucose iodine. Full stack of defect. Ultimately, it will happen. So,
Can you repeat the question?
because of,
Can you repeat the question?
I'm giving the patient glucose iodine in case of any radioactive leak. Okay. But you guys know that for the formation of this thyroid hormone, I need the enzyme which is thyroid peroxidase, right? So if I inhibit the thyroid peroxidase, okay, then also I can get the inhibition of the uptake of the iodine, right? So why I'm not giving the patient PTU or the methimazole or the carbimazole? Why just a glucose iodine? Or if I give the patient the replacement therapies for the thyroid, if I given the patient replacement therapies for the for this thyroid hormone, then it will give the negative feedback and it will inhibit the formation of the thyroid, right? So by this, I can also prevent the same condition. So why I'm not giving these drugs? Why I'm giving the glucose iodine only?
Are we leaking potassium out? And so this is a way for you to control the amount, or for your body to regulate the iodine coming in?
No. Right again. See, in case of radiation injury, you need to give the patient iodine. Okay, you need to just you need to inhibit the uptake of this iodine 131 as soon as possible, right? Without any delay. Is that okay? Because even please turn off your mic. Even if a slight bit of iodine 131 will be uptaken by the cells, it is sufficient to cause the damage, right? So you need to inhibit the uptake of this iodine 131 as soon as possible. If you give the patient propylthiouracil or this carbimazole or the methimazole, or you give the patient enzyme replacement therapies, all these drugs will take time to develop. Okay, and and in this time, sufficient amount of iodine 131 will be uptaken by the cells that can cause the carcinoma. So because of the slow action of these drugs, you cannot use the drugs for the radiation injury. You only use a glucose iodine because it is a very fastest way to prevent these conditions. Okay.
Yes, thank you.
So step 1 can also give you other options along with glucose iodine like the PTU, like the carbimazole, methimazole, or the enzyme replacement therapies, something like that. You won't choose them because all of these therapies will take time. Okay. You give the patient glucose iodine. Very important. Okay. So I think we should take a short break of 5 to 10 minutes and then we will meet again, right?
Yeah, okay. Excuse me. I have one
Yeah.
questions. I have a questions. There is like some research says like there is a when pediatric age group get exposure of multiple X-ray or CT exposure, high radiations, they later
Yes.
develop CA thyroid. So
Yes. The
so
papillary carcinoma mainly, I think.
yeah. So is that cases like this has any treating with this will prevent some radiations hazards?
Is there any way?
No, using this glucose
Glucose
iodine.
iodine?
Yeah.
No. It is only for the iodine leak, not
Okay.
for other conditions.
Okay. Thank you.
Okay, so we have discussed the radiation injury, why you need to give the patient glucose iodine, not other drugs, because they will take time and you need the instant, the instant action, and that is why the glucose iodine. Okay. Then comes the thyroid cancers. Okay, and yeah. First thing that is about the diagnosis, that you do the fine needle aspiration for the diagnosis of the thyroid cancer. Okay, you will inject the needle, you will draw out the fluid, and they will and then you will look for the cells which are present in the sample, right? You will see multiple type of cells. Some of them are the follicular cells, some of them special type of cells which are found in some specific type of carcinomas. And then by looking into the cells, you can say whether it is a papillary carcinoma, whether it is a follicular carcinoma, and whether it is a medullary carcinoma, right? But for a differentiation between the follicular carcinoma and between the thyroid adenoma, you always need to do the biopsy. Fine needle aspiration is not enough, because whenever you do the fine needle aspiration, you will see multiple colloids, okay, both in the thyroid adenoma as well as the follicular carcinoma. So the only thing that will be differentiate between the follicular carcinoma and the thyroid adenoma is to take the biopsy of the patient, and in the biopsy look for the capsular invasion. Okay, if the capsular invasion is there, that means it is cancer, it is malignant cancer. Okay, if the capsular invasion is not there, that means it is a benign cancer. Okay, and for every thyroid cancer, you will treat them with the thyroidectomy. Okay, before we go for the complications of the thyroid this surgery, okay, you first need to understand that a thyroid gland is present just anterior to the parathyroid glands. Okay, or I can say that the parathyroid glands are present just posterior to the thyroid gland. Okay, if you look at the blood supply of the thyroid gland, just give me a second. Okay, let us suppose this is my thyroid gland. Okay, for the blood supply, you have this the external carotid arteries here. Okay, you have the external carotid arteries on both the sides. Okay, and you have the arch of aorta. Okay, from the arch of aorta, you have the subclavian arteries. Okay, on the right side, and the subclavian artery on the left side. Of course, it is a brachiocephalic trunk which gives off first the external carotid, the common carotid artery. Okay, and then gives off the subclavian artery, the right subclavian artery. Okay, then this common carotid artery will be divided into the external carotid artery and the internal carotid artery. Okay, similarly here, we have a direct branch from the arch of aorta for that common carotid artery, and then it will form the external carotid artery and the internal carotid artery. Okay, and then you have a other left subclavian artery. Okay, so from these arteries, from the subclavian arteries, you have a trunk known as the thyrocervical trunk. Okay, the subclavian arteries gives off a branch known as the thyrocervical trunk. Okay, in both the sides. And from the external carotid artery, you have the superior thyroid artery. Okay, from external carotid artery, you have a superior thyroid artery. Okay, which are supplying the upper part of the thyroid. Okay, and from the thyrocervical trunk, which are the branch of the subclavian artery, you have the inferior thyroid artery. Okay, like that. Okay, so these are the blood supply, the superior thyroid artery and the inferior thyroid artery. Superior thyroid artery is a branch of external carotid artery, and the inferior thyroid artery is a branch of thyrocervical trunk, which are the branch of subclavian artery. Okay, then comes the nerve supply. Okay, let me clear this area. Now, for the nerve supply, you have the superior laryngeal nerve and the inferior laryngeal nerve. Okay, superior laryngeal nerve lie very close to the superior thyroid artery. Okay, and the inferior laryngeal nerve, which is or I can say the recurrent laryngeal nerve. Okay, it lies very close to the inferior thyroid artery. Okay, now the superior laryngeal nerve has two branches. Okay, the external branch and the internal branch, and it is the external branch of the superior laryngeal nerve which supplies a thyroid gland. Okay, and this branch lies very close to the superior thyroid artery, right? Similarly, you have the recurrent laryngeal nerve, okay, which supply most of the structures of the thyroid. Okay, and it lies very close to the inferior thyroid artery. Okay. The only structure which is supplied by the external branch of the superior laryngeal nerve is the cricothyroid muscle. Very important. External branch of the superior thyroid, external branch of the superior laryngeal nerve, it supplies the cricothyroid muscle. Okay, and rest all of the muscles of the thyroid are supplied by the recurrent laryngeal nerve. Okay, the internal branch of the superior laryngeal nerve, okay, it runs in this piriform recess, okay, and it supplies the sensory innervation, okay, for the cuff reflex. Very important, it supplies the sensory innervation for the cuff reflex, or I can say the afferent fibers for the cuff reflex. They are given by this internal branch of the superior laryngeal nerve. Is that okay up to here?
Yes.
Okay, now during the thyroid surgery, you need to ligate the superior thyroid artery and the inferior thyroid artery so that the bleeding complications won't occur. Okay, and during the ligation of these arteries, if you ligate the superior thyroid artery, then there are very high chances of of damaging the external branch of the superior laryngeal nerve. And if you ligate the inferior thyroid artery, then there are very high chances of damaging the recurrent laryngeal nerve. Okay, and while doing the thyroidectomy, when you remove the thyroid gland, there are very high chances to remove the parathyroid gland also. Okay, so three complications can occur. First is due to the removal of this parathyroid gland, and that can lead to the hypocalcemia. You will get the spasms, you will get the hyperreflexia, right? Second thing, due to the transaction of this recurrent laryngeal nerve, okay, by ligating the inferior thyroid artery, it can lead to the dysphagia, it can lead to the dysphonia, and mainly the hoarseness. Very important, step one will ask you what happened when you damage the recurrent laryngeal nerve. It can lead to the hoarseness, okay, or a very dull voice, or a very kind of rough type of voice. Okay, second and third complication, if you damage the superior laryngeal nerve, which is the external branch or the superficial branch of the superior laryngeal nerve, okay, if that happens, you will lose the voice tenor. Very important, if you damage the external branch of superior laryngeal nerve, it can lead to the loss of voice tenor. Okay, that generally is seen in the professional voice users only. Okay, and it happens by ligating the superior thyroid artery. Okay, superior laryngeal nerve, it supplies only the cricothyroid muscle. Okay, if that happens, you will lose the voice pitch, that can lead to the loss of tenor. Okay, if the recurrent laryngeal nerve become damaged, all other structures of the thyroid are supplied by the recurrent laryngeal nerve. You can have the hoarseness, you can have the dysphagia, because the cuff and the gab reflex, this vagus nerve will take part in these reflexes. Okay, so if you get the loss of cough, if you get a loss of swallowing, if you get a hoarseness, that means you have damaged the recurrent laryngeal nerve. If you get a loss of pitch, okay, or a loss of tenor, that means you have damaged the external branch of superior laryngeal nerve. And the third complication is the parathyroid gland removal, which can cause the hypocalcemia. Is that okay up to here?
Could you please explain the loss of tenor?
How can I explain this loss of tenor? I mean, what way?
Like, why is it happening actually?
Because of this muscle. This muscle is responsible for the pitch formation in your voice, high pitch. Okay, the high pitch is because of this cricothyroid muscle. Okay, and if this muscle is lost, then you can have a loss of tenor because of that. And to listen to the voice, you can search the Google how this look like. Okay.
Okay. Thank you.
Okay, so now the type of cancers, we have discussed the cancer surgery. Okay, you need to ligate the superior artery, you need to ligate the inferior artery, you need to remove the thyroid. And while doing that, you can have three complications. Okay, the damage of the superior laryngeal nerve, the damage of the inferior laryngeal nerve, and the removal of the parathyroids also. Now, type of cancers, you need to understand four cancers. One and the most common type is the papillary carcinoma. Second is the follicular carcinoma, and third is the medullary carcinoma. And the rare one is the undifferentiated or the anaplastic carcinoma. Okay, for the papillary carcinomas, first you need to look for the risk factors. Okay, and a very important thing, You must remember every risk factor for the papillary carcinoma. First is the RET PTC rearrangement. See, it is not the RET mutation, but it is a RET PTC rearrangement. If you have a RET mutation, then you can have which syndrome? MEN1 or MEN2?
MEN2.
Exactly. You can have a RET. You can have the MEN2 syndrome in case of RET mutation. In case of rearrangement, you can have a papillary carcinoma. Second is the BRAF mutations, very important. And third is the childhood radiations. Okay, so these three are the risk factors for the papillary carcinoma. Then you need to look at the findings of the papillary carcinoma. First thing, of course, you will get a unilateral nodule in the thyroid. Okay, and when you do the biopsy or the fine needle aspiration of that nodule, what you will see first are the overlapping cells. As you can see here, most of the cells are overlapping each other. See, look here, right? If I zoom again more. Yeah. See here, most of the cells are overlapping each other. So this is the first feature. Second feature is the empty nucleus. As you can see, this is a whole cell. Okay, this is a whole cell which are overlapping other ones. Okay, and this is the nucleus of the cell. And as you can see, the nucleus is clear. Okay, so empty pale nucleus or the clear nucleus is the second important characteristic feature of the papillary carcinoma. Third feature is the nuclear grooving. If you look in this nucleus, as you can see here, you see this rod-like structure. Okay, and this is the nuclear grooving. It is a groove in the nucleus. Okay, you can see that here also, right? Here also. Okay, here also, as you can see. So nuclear grooving is the third important structure that you will see. And fourth is the formation of Samboma bodies. Does anyone remember what is a Samboma body?
Calcification around a fibrovascular stock.
Exactly. So you will see the calcifications also.
Laminar
Okay,
calcification.
in the form of concentric layers, right? So the Samboma bodies, nuclear grooving, empty nucleus, and the overlapping of the cells. These are the four important features of the papillary carcinoma. Okay.
Okay.
Any doubt? Remember these three factors, remember the findings. Okay. And symptoms, no symptom will be occurring. It's just a thyroid nodule you will see. And when you do the fine needle aspiration of this nodule, you will see all these features. Okay.
Yes, sir. About the overlapping nodules. So is that just like the normal, like how you could hear in lack of like, it just like all tumors pile on top of each other, or is this like a very specific type of overlapping?
Not a very specific type. It is not specific. It is kind of common among many other tumors.
Okay.
Okay. As you can see, in case of thyroid adenoma, also you will have the overlapping of the colloids, right? So overlapping is because of all the crowding of the cells inside the tumor, right?
Okay. Okay.
But you won't see that in the normal tissues, right? Normal tissues had lots of space inside them. Okay, with the abundant stroma. So you won't see this overlapping thing in the normal tissue, but only in the cancer. So overlapping is kind of a hallmark feature, you can say. Not a hallmark, but I think it is just a feature of the cancer. Okay.
All right. Thank you.
Okay, then comes the follicular carcinoma, and like I told you, the fine needle aspiration is just not enough. You can see the all the colloids in case of this carcinoma as well as this the thyroid adenoma. So in order to differentiate between the follicular carcinoma and the thyroid adenoma, you will do the biopsy of the tissue. And once you do the biopsy, you will look for the capsule. If the invasion is there, that means it is a carcinoma. If the invasion is not there, that means it is a adenoma. Okay. Then you look. Then you need to know all these conditions, all the risk factors for this follicular carcinoma. Okay, it is a RAS mutation, BRAF for the papillary, RAS for the follicular. And what other cancer the KRAS can cause? RAS mutations can cause other cancers.
Colorectal, lung, and pancreatic.
Exactly. Colorectal, lung, pancreatic, and the follicular carcinomas are because of the RAS mutations. Okay. And what other cancer the BRAF mutations can cause?
Melanoma.
Melanoma. Good.
Non-Hodgkin.
And in hematology, what cancer?
Hairy cell.
Hairy cell. Good. Okay, so one is the RAS mutation, and second is the translocation of PPAR gamma and PAX8 gene. Very important. Translocation of PPAR gamma and the PAX8 gene, and second is the RAS mutation. They can cause the follicular carcinoma. Okay, capsular invasion is the highly characteristic feature of the follicular carcinoma, which will be which will help differentiating it with the adenomas. Then you get the medullary carcinoma, and medullary carcinoma is the tumor of the parafollicular C cells. And these parafollicular C cells, they releases the calcitonin, right? And because because they're releasing the calcitonin in a very high amount, it can become the amyloid. Okay, if they if from the alpha helical structure, they will be converted into the beta plated sheets. Okay, and they become resistant to degradation, and that can lead to the formation of this amyloid. Okay, so whenever you do the biopsy of the patient, what you will see, the deposition of the amyloid first. As you can see, everywhere is pink, a diffuse homogeneous pink. Okay, and this is the H&E stain. I must say, this is the H&E stain. When you do the congruent staining, okay, you will get a red everywhere. When you do the apple green bifringence, you will get the green areas, right? So this is the H&E staining. In the H&E staining, you will see the diffuse pink areas. Okay, and this is a highly important features of the amyloid. And you can see all these cancer cells in the background of the amyloid, right? And these are all the parafollicular C cells. Step 1 will also describe them as the spindle cells. Okay, and spindle cells is just a common term for any stromal cell, because you know that all these parafollicular C cells, they lies in the stroma, right? You have all these colloids, and in between the colloids you have the stroma. Sorry, in between two follicles you have the stroma, right? And these are the stromal cells, the medullary cells, right? So spindle shaped cells are all the cells, and this is a common term for all the stromal cells, right? So they are the spindle shaped cells or the polygonal cells. They release the calcitonin, which will become amyloid, deposit in the tissue around the blood vessels, can cause amyloidosis. Okay, and it is associated with the RET mutations. Very important. Medullary carcinoma is associated with the RET mutation, the MAN2A and the MAN2B syndrome. Okay, so whenever I say the RET mutation, it is the MAN2A, MAN2B. It will be the parafollicular C cell tumor. When I say the RET and the PTC rearrangement, it would be the papillary cancer. When I say BRAF mutation, it would be a papillary cancer. When I say the radiation, it would be the papillary cancer. When I say the RAS mutation, it would be the follicular. And when I say the PPAR gamma and the PAX8 rearrangement, it will be the follicular cancer. Remember, all of these mutations highly important. Step 1 can ask you these things. Okay, remember the features of every cancer. Okay, the empty nuclei, the grooving of the nuclei, overlapping of the cells, SAMO bodies, amyloid, okay, and the capsular invasion. You can easily differentiate based on the histology also. If they give you the histology, you just need to look at the characteristic features. You will be able to identify them. Then come the undifferentiated and the anaplastic tumor. And the anaplastic tumor is like most extreme case of any tumor. Okay, when the cell just just dividing and do not just focusing on the function and in any way. Okay, the cell is just dividing. Okay, and the cell will become very highly undifferentiated type. You just cannot look at the region of the tumor anymore. Okay, and this tumor is known as the anaplastic carcinoma, and this anaplastic carcinoma has the highest grade. Okay, remember the gradings you give to the tumor? Yes, the staging and the grading, remember?
The TMN?
Yeah, TNM staging and the gradings. Then from general pathology lectures, you must remember this, right?
Yeah. Others
Okay. Yeah.
like stage 1, 2, 3, 4.
And the stages are based on the differentiation, right? Stages are based on the differentiation, first thing, mitotic figures, okay, and the cell arrangements, if you guys remember, right? So these anaplastic tumors, they have a high mitotic activity. They have no differentiation at all. Okay, even you can see the giant cells in case of anaplastic carcinoma. The cells become so much abnormal that they even form the giant cells within the tumor. Okay, so this is a feature of the anaplastic carcinoma, a highly undifferentiated tumor. Okay, this tumor has the highest grade. Okay, generally seen in the older patients. Okay, it will after growing, it can compress the other structures also. You can get the dysphagia, you can get the dyspnea, you can get the hoarseness, and the prognosis is very poor. Okay, and it is generally associated with the TP53 mutations. Okay, any doubt on the cancers?
No, no.
Okay. Then you need to know how to diagnose a parathyroid disease. For a normal patient, the calcium levels and the PTH levels lies here. Okay. When you get a low calcium level and a low PTH level, that means it is a primary hypoparathyroidism. Okay. Because of loss of PTH, you are having a loss of calcium, right? So both low PTH and the low calcium is there. Causes can include a surgical resection, which happens generally with the tumor, with the thyroid surgery, because you know that one of the most important complication of this thyroid surgery is the removal of parathyroid glands. So surgical resection can occur and autoimmune can occur. Okay. If you have a high PTH level and a low calcium level, that means the primary disturbance is in the calcium. And because of the low calcium levels, the PTH level will rise to maintain the blood calcium level. And this is known as the secondary hyperparathyroidism, where you have low calcium, and high activity of the PTH. It could be due to the low vitamin D. Okay, it could be due to the low calcium at first stage, or it could be due to the chronic kidney disease. Okay. Third scenario, where you have a high PTH level as well as a high calcium. This is known as a primary hyperparathyroidism, in which this high PTH causes a high calcium. Okay, it could be due to the hyperplasia, it could be due to the adenoma, it could be due to the carcinoma. And the fourth scenario, where you have a low PTH but high calcium, it may be due to the higher vitamin D intake, okay, or it could be the high this calcium intake, or it could be due to the cancer. Certain cancers which can directly invade the bone, they can cause a resorption, they can cause the high calcium. Certain tumors, they will release the vitamin D, or they activate the vitamin D and they can cause the high calcium levels. Certain tumors, they will release the parathyroid related peptides, okay, and they can cause the high calcium levels. And whenever the calcium level rises, the PTH level will form. So sometimes step one can give you some of these graphs. They will give you some of the risk factor in the patient, and based on the risk factor, they will ask you what graph would be present in this patient. So they will give you the normal value and they will ask you A, B, C, or D option. So you need to choose that. Is that okay?
Yeah.
Okay, then let's discuss the hypoparathyroidism. Okay, and the hyperparathyroidism occur when you remove the thyroid glands, when you remove the parathyroid glands while doing the thyroid surgery, which is the most common cause. Okay, second thing would be the autoimmune destruction. A congenital cause would be the DiGeorge syndrome, which is a 22q11 microdeletion that can cause the hyperparathyroidism along with some cardiac and the facial defects. Okay, because of the loss of calcium, what you have is the tetany and the hyperreflexia. You will have the spasms. Okay, you will have the hypocalcemia. You will have the tetany. You will have the hyperreflexia. And two important signs are the Schwarzschild and the Trousseau sign. Remember the Trousseau sign, it is also for the pancreatic cancers, okay, where you have this migrated thrombophlebitis, right? The same scientist who developed that sign, same scientist developed this Trousseau sign also, okay? So for the Schwarzschild sign, you tap on the facial nerve, you tap on the cheek, okay? And when you tap on the cheek, you will see the contraction of the facial muscles. And that's how you know the patient is having a spasms or hypercontraction. Okay, this is a Schwarzschild sign. Then comes a Trousseau sign, in which you just you apply a BP cuff. Okay, you inflate it, you compress the brachial artery, and while doing that, you will have the carpal spasms. Okay, so while measuring the BP, if you encounter a patient having a carpal spasms, that means he is having a hypocalcemia. Other important signs of the hypocalcemia include the constipation. Okay. Why constipation? Because they inhibit the sodium channels and they inhibit the neurotransmission. Sorry about that. Not the constipation, because it is a feature of hypercalcemia. Just give me a second. I'm a bit confusing here. Just give me a second. Yeah, constipation is a feature of hypercalcemia, not the hypocalcemia. Okay, sorry about that. You will get the spasms. Mainly the feature is spasms, hyperreflexia, okay, and the shiverstick and the trousseau sign. You will also get the sensory dysfunctions. Very important. Sensory changes would be there. The paresthesias will also be there. Okay, so yeah, that would be all the symptoms of the hypercalcemia and hypocalcemia, and it is because of the hypoparathyroidism. Causes includes the destruction, Dijon syndrome, or the surgical removal. Then you have two diseases, which is the pseudo hypoparathyroidism type 1A and pseudo hypoparathyroidism. Okay, in the pseudo hypoparathyroidism, you have an imprinting in the GNAS gene. Okay, which is the GS alpha activating gene. Okay, it codes for the GS protein. Very important. And does anyone know how the imprinting occur?
DNA methylation.
Exactly, DNA methylation. So what's gonna happen? These are the autosomal dominant disorders. Okay, and they involve the mutation in the maternally transmitted genes. Only the maternally transmitted genes will become affected. Okay, imprinting occur, and as a result, the GS protein will be lost now. And as a result, because the GS is not there, and you guys know that the PTH works through the cyclic AMP. Now all the receptors, all the organs, especially the kidney and the bones, they will become resistant to the PTH. Right? Kidney and bone, they won't be responding to the PTH. The patient will have high levels of these PTH, but low level of the calcium and high level of phosphate, because you guys know that in case of kidney, this parathyroid hormone will cause the reabsorption of the calcium and causes the loss of potassium. Okay, so ultimately decreasing the blood phosphate level and rising the blood calcium level. So in case of pseudo hypoparathyroidism, you will have the high PTH, but because all the receptors will become resistant to it because of the mutation, you will have the low calcium and high phosphate. And other important thing is the Albert hereditary osteodystrophy. Okay, in which you have the shortened fourth and the fifth digit. Very important. Okay, and yeah. Does anyone remember the other areas where we studied these DNase mutations? Anyone remember? In the biochemistry, we have discussed the DNase mutations also somewhere. No?
Can you repeat?
Yeah? Which disease?
Sorry, I couldn't understand what you were saying. Could you just repeat it?
In
What did you ask?
biochemistry lectures. In biochemistry lectures, we have discussed one more disorder who has this GNAS mutations. If anyone remember, in biochemistry, we have discussed this. GS activating mutation, something like that, remember? The McCune-Albright syndrome. Remember?
Yes.
McCune-Albright syndrome, okay? In the McCune-Albright syndrome, you have this autosomal dominant or autosomal recessive. Anyone? No?
No.
I thought it was.
It was, yeah, say.
It was in the when you were learning in the genetics, right?
Yeah. So it was dominant or recessive. It was mosaicism. Please remember
Yeah.
the example of mosaicism, guys. It's highly important. Okay. Don't forget it. Mosaicism, the McCune-Albright syndrome. Okay, in the same way you have the GNS mutation in the McIlroy syndrome, the same mutations are in the hypoparathyroidism also, the pseudo hypoparathyroidism type 1A. Okay, don't forget that it is autosomal dominant, but the McIlroy syndrome is the example of mosaicism. Okay, then comes the pseudo hypoparathyroidism, which is autosomal dominant again, and it is a mutation in the parentally transmitted genes. Okay, imprinting in the GNAS. Okay, but in that case, you won't be having any end organ damage. Sorry, any end organ resistance. Okay, so you have the symptoms. The physical findings will be similar to that of pseudo hypoparathyroidism, in which you have the shortened fourth and the fifth digit. Okay, but the blood calcium level, the parathyroid hormone level, and the phosphate levels, these are all normal. So okay, so if you get a normal calcium, hormone, and the phosphate, and along with the shortened fourth and fifth digit, that means it is a pseudo hypoparathyroidism case. If you get the if you get the high level of the hormone, low level of the calcium, and high level of the phosphate, along with this syndrome or this symptom, that means it is a pseudo hypoparathyroidism type A. Don't forget these two conditions. Okay. Then the lab values in other type of hypocalcemias. Okay, first is a vitamin D deficiency. When you have the vitamin D deficiency, ultimately you're gonna have a low level of phosphate, because vitamin D is important for the absorption of the phosphate also. So low level of calcium will be seen, low level of phosphate will see, and the patient will also have a high level of parathyroid hormone. Okay, and because of this high level of parathyroid hormone, it will also contribute to the low level of phosphate, because high PTH will always causes the low blood level of phosphate. Then comes the hypoparathyroidism, in which because of loss of PTH, you have the low calcium level, and because the PTH is not there, so loss of phosphate will not occur. Okay, reabsorption of phosphate will occur in the kidney, and that can lead to the hyperphosphatemia. In the chronic kidney disease, okay, you have excessive phosphate. Okay, and because of the excessive phosphate, all the phosphate will bind to the free calcium. Okay, and as a result, the free calcium level will decrease in your body, so you will get the hypocalcemia. And because the free calcium level is decreasing, it will give some negative feedback to the parathormone, and as a result, you will get the high parathyroid hormone level. Okay, then comes the pseudo hypoparathyroidism. We have discussed that you are having a high level of PTH, low level of calcium, and high level of phosphate. In the hyperphosphatemia, you have high level of phosphate. Okay, and similar to that of this CKD, this high phosphate will bind to the calcium, decreasing the calcium levels, causing the hypocalcemia, increasing the parathyroid hormone level, causing the hyperparathyroidism. Okay, so these are some lab values in case of hypercalcemia. You need to differentiate between all of these values. Very important thing. Okay. Then hypercalcemia in the malignancy. I've told you that some of the hormones, they release the parathormone like related peptide, and these are the lung cancer, the squamous cell carcinoma of the lung, the renal cell carcinoma. These are the two important ones to remember. Then bone metastasis directly can cause the bone resorption by activating the osteoclast cells. Okay, and the cancer includes a breast cancer, multiple myeloma mainly. Okay, some other cancers which work to the vitamin D. Okay, and it is not the cancers mostly, but the autoimmune conditions like the sarcoidosis, like any other granuloma. Okay, and yeah, that would be all. And you need to differentiate between the benign cases and the malignant cases of the hypercalcemia. If you have a calcium level which is more than 13, okay, if you get any question in which the calcium level is more than 13, that means it is because of the tumor only. And if you get a calcium level which is around 12, less than 13, less than 12, okay, sorry, more than 12 but less than 30, this 13, that means it is a cause of hyperparathyroidism or other causes, but not the cancer. So for the cancer, you have a very high level of calcium, more than 13, very important. So calcium level more than 13 are highly suggestive of the malignancy. Yeah, that would be all. And one more thing, which is the hungry bone syndrome. Okay. So for the patients who have a very prolonged history of the hyperparathyroidism, a very prolonged history of hyperparathyroidism, and if you do the parathyroidectomy in those patients, okay, a patient with a very prolonged history of hyperparathyroidism, and you do the parathyroidectomy in those patients, then suddenly the the PTH levels will be fall. Okay, and because the PTH is responsible for the resorption of the bone, so as soon as the PTH level will drop, okay, the bone formation will occur, and all of the calcium which is in your blood, okay, it will be uptaken by the bones, okay, and you will get the hypocalcemia and hypophosphatemia. And why is that? Because of the rapid redistribution of the phosphate and the calcium, and this is known as the hungry bone syndrome. It is a very acute cause of hypocalcemia and hypophosphatemia because of removal of the parathyroid glands, okay, and generally seen in the patients with a chronic hyperparathyroidism. Because of the hyperparathyroidism, you're having the resorption of the bone and very chronically, right? So that's why the name hungry bone syndrome. Any doubts so far?
Dr. Chaudhary, one question.
Here to ask.
Earlier you mentioned Schwostek sign with pancreatitis and some thrombophlebitis. I didn't understand.
Signs. Don't worry, just wait for the GIT. You will encounter the pancreatic adenoma. Okay, so there is a sign in the pancreatic adenoma, which is a migratory superficial thrombophlebitis. Okay, and that sign is developed by the scientist Trosio, and the same scientist is developed this sign also. Okay.
Okay.
Just wait
you're
for the
saying
GIT. Yeah.
okay. And you're saying that in pancreatitis, you get which sign?
Not in the pancreatitis, but in the cancer of the pancreas, the pancreatic adenoma, the migratory superficial thrombophlebitis. Okay.
Okay. Thank you.
Same sign is diagnosed by this scientist Trosio, and the same thing is for the scientist. Okay. So same scientist in both the areas. Okay. Then comes so we have discussed the hyperparathyroidism. Okay. And now comes the hyperparathyroidism. So normally it is because of the cancer or because of the hyperplasia. Okay. And does anyone remember in what syndrome, in man 1 or man 2, you get the parathyroid adenoma?
Man one.
Man 1.
Not in man 2.
Man 2. 2A.
One.
What?
In man 2A also, or see, both in the man 1 and man 2A, or just only in the man 1, the parathyroid adenoma?
Both men's.
Actually, parathyroid adenoma is in men 1, and men 2 you have hyperplasia.
Exactly. Don't forget this point. In the for the parathyroid adenoma, it is only in the man 1. Okay. And the hyperplasia is both in the man 1 as well as man 2A. Okay. Remember this fact. Very important. Okay. So whenever you have a hyperparathyroidism, you're going to have a high level of calcium, first thing, which is the hypercalcemia. And because the calcium level in your blood is rising, the filter load of the calcium in the urine or in the PCT is also rising. As a result, you will get the hypercalciuria. So a very characteristic feature of the hyperparathyroidism is the hypercalcemia with hypercalciuria. Okay, very important. And because of this high calcium level in your urine, you can get the renal stones, right? And because of the high calcium level, they will calcify the collecting duct and they will cause the diabetes insipidus. That's why you can get the polyuria polydipsia. Okay. And because of the high PTH levels, you will get the hypophosphatemia, right? So, and you guys also know that whenever you have a high PTH activity, you will have a high activity of the cyclic AMP, which you can detect in the urine. So you will have a high increased urine cyclic AMP levels. And whenever you have the resorption of the bone, the osteoblast will always activate to, to compensate it, right? And the osteoblasts require the alkaline phosphate. They require the alkaline media, right, for their function. Okay, so that's why they have the enzyme which is known as the alkaline phosphatase. Okay, so whenever you have a high PTH level or the bone resorption, you will always have the high activity of osteoblast cells. Okay, and they will secrete the alkaline phosphate. So for the hyperparathyroidism, you have the hypercalcemia, hypercalciuria, hypophosphatemia, high PTH level, high alkaline phosphate, high urinary cyclic AMPs. Okay, Most of the times they are kind of asymptomatic, right? But then other times they have this bone pain because of the bone resorption. They will get the osteoporosis. Cystic which changes appear in the cortex of the bone. As you can see, these are the cystic changes in the cortex of the bone. Okay, because of the bone resorption. And similar things you can also get in the hyperthyroidism. Remember, you can get the bone resorption osteoporosis also in the hyperthyroidism, right? And in the same way, you can get the bone resorption in the primary hyperparathyroidism. Okay, you will get the cystic spaces, and that's what it look like in the X-ray. Okay, some dark areas. Okay, then you will have the constipation because of the high calcium. Because of the high calcium level, they will inhibit the sodium channels, and when the sodium channels are inhibited, no nerve impulses could be transmitted, and as a result, you will get the loss of GI motility. Okay, you will get the abdominal pain, flank pain because of the stone formation. Okay, you can also get the acute pancreatitis because calcium is the activator of many enzymes. Okay, and calcium will also activate the enzymes, the proteases in the pancreas, and so that it can cause the acute pancreatitis. Please remember this cause of the acute pancreatitis. We will list all the causes later. Okay, so it would be better if you just remember these causes. Then you also get the new psychiatric disturbances. Okay, very important. One disorder which is known as the osteitis fibrosa cystica, in which you will get the cystic bone spaces filled with the brown fibrous tissue. It is also known as the brown tumor. Actually, it is not a tumor; it's just a cystic spaces which are filled with some fibrous tissue, which is kind of brownish in the appearance. Okay, and it consists of the osteoclast and the deposited hemocytin from the hemorrhages. Very important, right? And you guys already know that for the this parathyroid hormone, it will first activate the osteoblast, and after activating the osteoblast will release the rank ligand that will bind to the rank receptor on the osteoclast to activate them. Osteoclast will be activated to cause the bone resorption, and bone resorption first start at the periphery, or I can say the cortex. Very important. Bone resorption in case of parathyroidism, it will start first in the cortex and then to the medulla. While in the natural cause of the osteoporosis, the age-related causes, okay, the bone resorption start first in the medulla and then to the cortex. Opposite. Okay. So you will get the subperiosteal thinning because after the periosteum you have the cortical layer. Okay, and from that layer you have the loss of collagen, loss of calcium, loss of phosphate. Okay, and that can cause the cystic spaces, as you can see. Okay, it is generally associated with the primary hyperparathyroidism, but can also be seen in case of secondary hyperparathyroidism. Okay, and so now we will discuss the secondary hyperparathyroidism. It is because of the loss of calcium. Okay, the first thing for the secondary hyperparathyroidism is the loss of calcium. Okay, and it can be happen because of low vitamin D. Okay, sometimes, and sometimes because of a low calcium intake also. Okay, so for the secondary and you can also have the secondary hyperparathyroidism with the hyperphosphatemia, right? Because the function of the parathyroid hormone is to lower the phosphate levels and to increase the calcium levels, right? So whenever you have a high phosphate level or low calcium level, you can get the secondary hyperplasia of the parathyroid gland. Okay, so kidney diseases like the chronic kidney disease, okay, hypervitaminosis D. Okay, sorry, in the chronic kidney disease, you will get the hypovitaminosis D. Why? Can anyone tell me? We have discussed that earlier.
1-alpha hydroxylase.
Okay. And what protein or what substance inhibiting this 1-alpha hydroxylase?
Calcium inhibits it.
No, not calcium. In case of chronic kidney disease, what protein or what substance is inhibiting the 1-alpha hydroxylase? We have discussed that already in the biochem lectures. If you guys remember from the vitamin D part, we have discussed that.
Phosphatemia?
No. Remember the fibroblast growth factor?
No, I'm not getting it.
Fibroblast 23.
Yes. FGF23 is released by the osteoblast cells, right? In order to
Yes.
counter the increased absorption of the phosphate, right? But what happens ultimately? It will inhibit. See, because of the vitamin D is causing the absorption of the calcium and the phosphate in the GI tract, right? When the body gets a chronic kidney disease, what's gonna happen? The excretion of the phosphate is decreased. Okay, now the compensatory mechanisms will get activated and they will inhibit the vitamin D so that the absorption of the phosphate can never happen, right? But what happened, with the later diseases, as the kidney further fails, okay, the excretion of the phosphate is completely stopped. Okay, so even though the vitamin D is low, the phosphate levels are keep on increasing. Okay, but one thing is happening, which is the loss of calcium, because vitamin D and is not there to cause the calcium absorption, right? So ultimately, because of the chronic kidney disease, you will get the low calcium level, high phosphate level, low activated vitamin D levels, and high levels of this the parathyroid hormone. Okay, and this is the hypocalcemia in the chronic kidney disease, and this is the thing which causes the renal osteodystrophy. Okay, and the renal, in case of renal osteodystrophy, you will also get the osteitis fibrosa cystica. Don't forget that, please. In case of renal osteodystrophy, you will get the osteitis fibrosa cystica, and it is because of the kidney failure. That's why the name renal osteodystrophy. Okay.
Dr. Chaudhary, could you
Yes.
explain what FGF23 alpha does again?
These FGF23, they actually released by the osteoblast cells to inhibit the enzyme 1-alpha hydroxylase, so that the 25 hydroxy vitamin D3, which is the stored form in our body, inactivated stored form of vitamin D3, okay, it cannot become the 1,25 dihydroxy vitamin D3, which is the activated form. Okay, and it happens in the kidney. This 1-alpha hydroxylase is present in the PCT of the kidney. So what happens is the fibroblast growth factor 23, they will come to the PCT, they will inhibit the enzyme so that the vitamin D3 can never be activated, and as a law, and as a result, the phosphate and calcium will be start excreting from the kidneys, and their absorption will be inhibited in the body, and this is a mechanism to counter the increased levels of phosphate. Okay.
Okay, thank you.
FGF23 prohibit the turnover of bone?
FGF23?
Yeah.
No, I think it was different. It was, I think, you're talking about that. Just give me a second.
Yeah, I'm sorry. I'm missing something.
Yeah, exactly. You're talking about the achondroplasia, right?
Yeah.
In case of achondroplasia, it was fibroblast growth factor 3, not 23.
Okay.
Okay, it was 3 in case of achondroplasia, but 23 in case of this the chronic kidney disease. Okay.
Okay.
I have a question.
Yeah.
So you're saying because of the hyperphosphatemia, the calcium levels are decreased. So
Yes.
that's gonna make the osteocytes get stimulated, and they're
Yes.
gonna release the fibroblast growth factor 23.
Osteoblasts are secreting the fibroblast growth factor.
Osteoclast to release. The osteoclast will release.
Osteoblast B.
Oh, okay. And then
Osteoblast releasing these fibroblast growth factors.
okay, and then that's gonna decrease the phosphate reabsorption in the proximal tubule.
Yes, exactly.
So then basically elevated levels of phosphate.
Not the reabsorption,
so elevated,
not the reabsorption, but the absorption in the GI tract. Okay, because excretion can never happen. Kidneys failed already, right? Excretion is already very much decreased. Now you need,
no, I mean reabsorption.
no, not the reabsorption, but the absorption in the GI tract.
Okay.
Reabsorption is
Oh,
already
so
very
it's the
much high.
opposite.
Reabsorption is already very high in the kidney, and the kidneys are failed, like, so they cannot excrete the phosphate anymore. Okay, so body had to compensate it by decreasing the absorption of the phosphate in the GI tract, and which happened with the support of vitamin D. So body needs to inhibit the vitamin D so that the absorption of the phosphate in the GIT can never happen. Okay. Is that okay? You can ask your doubt if you have any more.
So ultimately, you're just gonna have decreased calcium in the intestinal and then decreased phosphate absorption. So you're gonna have worsened hypocalcemia.
Yeah, that actually worsen the conditions. Yes, they have no effect on the phosphate ultimately, but because of these fibroblast growth factors, you're having a very low calcium because vitamin D is not there to absorb the calcium, right? So they they did nothing for the phosphate, but they did for the calcium. They decrease the calcium levels ultimately. At the initial stages, they are kind of very much helpful to in maintaining the phosphate levels, but at a very initial stage only. Okay, as a disease progress, this mechanism will fail.
And then the long-term increase in parathyroid hormone, that's gonna eventually lead to osteoitis fibrosis.
Because a PTH will try to maintain the calcium levels. In order to maintain the calcium level, it will
it's gonna stimulate the osteoclasts to increase the bone turnover.
Bone resorption.
And that's when you're gonna get the bone pains and stuff like that.
Yeah, exactly.
Okay, I understand. Yeah.
Okay, any more doubt, anyone?
Sorry about that.
No problem. Any more doubt, anyone?
Yeah, one more question. So FGF23 alpha, it reduces the GI absorption of phosphate and calcium. That's one function. Is there any other function?
No, that much I only know about this fibroblast factor. They're actually inhibiting the vitamin D. Okay, they're inhibiting the vitamin D. So every function which is this vitamin D performs, it will be inhibited. Okay. Every function of vitamin D is inhibited now.
So how does it improve how does it improve the calcium? You were saying it improves in secondary hyperparathyroidism, you already have a reduced calcium. So aren't you making the calcium even lower by
exactly, that's what's happening.
That's what's happening. Okay.
Yes. The mechanism was to maintain the phosphate levels low. Okay. But instead it was getting the calcium low instead, right? It has no function on the phosphate ultimately at the very later stages. Okay, but it will make the calcium very low in your body instead. Okay.
Okay, got it. Thank you.
Okay, so step one will ask you why you get the constipation in the hypercalcemia. They literally ask this. Okay, so for the hypercalcemia, they inhibit the they inhibit the nerve transmission by inhibiting the sodium channels, and as a result, the smooth muscle contraction in the GI tract won't happen, and as a result, the colonic motility will be inhibited. Very important. Then comes the tertiary hyperparathyroidism. Okay, in which you have a high level of this parathormone releasing hormones. Okay, and you also get it from the chronic kidney disease ultimately, in which you have a very high calcium level as well as the high PTH levels. This is a tertiary hyperparathyroidism in which you have a high calcium level as well as the high PTH levels. Okay. Okay, then comes a condition which is known as a familial hypocalciuric hypercalcemia. See, in case of primary hyperthyroidism, you're having a hypercalcemia with hypercalciuria. But in this condition, you're having a hypocalciuria. I told you, whenever you have a high calcium level in the blood, okay, you're ultimately going to have a high filter load of the calcium in the GFR. And as a result, high calcium will be in the urine, right? But in this condition, the calcium sensing receptors, which are present in the DCT, which senses the calcium and they release the PTH. Okay, what's going to happen? Whenever the calcium level is increased in your body, okay, the calcium sensing receptors will be activated, okay, and they will inhibit the PTH. Okay, but now because of the mutation in these receptors, okay, the affinity of these receptors for the calcium is decreased. Okay, now more calcium is required to activate these receptors. Okay, so because these receptors won't activate at a normal or a slightly increased calcium levels, they will act, the PTH will keep on activating, right? And when the PTH is activated, it will cause the reabsorption of the calcium from the PCT, loop of family, or DCT or collecting duct? Where?
DCT.
PCT. P for parrot.
Yep.
No, DCT.
D for Delhi.
Yeah, D for Delhi. DCT. Okay. Please remember that fact. So what's gonna happen because of the mutations? DCT it is. D for dog. Okay. So because of the mutations in these receptors, okay, they won't be sensing the calcium. Okay, so they require very high calcium level in order to get activate and in order to inhibit the PTH. So when the patient have a slightly increased levels of the calcium, these receptors are still inhibited, and as a result, the PTH will keep on causing the reabsorption of the calcium, and as a result, you will get the high calcium level in the blood and low calcium level in the urine, along with high PTH levels. And this is known as the familial hypocalciuric hypercalcemia. The name itself is saying everything. You have a low calcium in the urine and high calcium in the blood. It is because of the defectiveness in the calcium sensing receptor. And step 1 will ask you what kind of receptor these calcium sensing receptors are. And these are the G protein coupled receptors. A very important thing, step 1 will ask you what kind of receptors they are. These are the G protein coupled receptors. Any doubt?
No.
No, it's good.
Yeah.
No doubt.
Okay. Now a very important topic, the diabetes mellitus. First, you need to know about the acute manifestations when you have a sudden increase in the blood glucose level. Okay. And especially I'm talking about a type 1 diabetes mellitus, because two type of diabetes are there, the type 1 diabetes mellitus and the type 2 diabetes mellitus. These symptoms are mainly for the type 1. Okay, you will get the polydipsia, you will get the polyuria, you will get the polyphagia, you will get the weight loss. Okay, and why does the weight loss is occurring? Can anyone tell me?
Because of glucose loss in the urine.
But glucose levels are already very much high in your blood. That's why it is being lost in the urine, right?
Your insulin can't
cannot go inside the cell.
Okay, then
Fat synthesis cannot occur because of insulin deficiency, insulin resistance.
What thing cannot occur?
Fat synthesis.
Okay, then.
So glucose cannot be converted more into like fat synthesis for fatty acid synthesis.
Okay, any more thing above fat?
After you burn, you're gonna get rid of fat, right?
Yes, cell will use
To
the fat.
get energy. So you're gonna get
and
a
when
reduction in your weight.
and when the fat is lost, the cell will thrive on the protein, right? So you will get the muscle wasting, you will get the weight loss because of that, because the glucose is not available for the cells. So cell will start taking the fats, the ketone bodies, and then the proteins. Okay. So these are the highly specific features for the type 1 diabetes mellitus. And the diabetic ketoacidosis, it is only specific to the type 1 diabetes. Okay, type 1 diabetes, the diabetic ketoacidosis, it is very specific for the type 1 diabetes only. Okay, and you get the hyperosmolar hyperglycemic state in the type 2 diabetes. Okay, hyperosmolar hyperglycemic state in type 2 diabetes, and the diabetic ketoacidosis in the type 1. And that's why type 2 diabetes is kind of more dangerous than the type 1, because in type 1 you're having this ketoacidosis which will produce the symptoms like the fruity odor and this metabolic acidosis and everything, right? So you will get the symptoms first. But in case of this hyperosmolar hyperglycemic state, you won't get any symptom. Okay, and the patient eventually die without without any symptoms. Okay, that's why these are very important. Type 2 diabetes. Okay, rarely, because they can be caused by the unopposed secretion of the growth hormone that we have discussed, the acromegaly case. You can get a diabetes mellitus in that case also. Okay, epinephrine can also cause the high glucose level. We have discussed that. Okay, and this can also be seen in the patients with the glucocorticoid therapy, because the cortisol is actually it actually causes the gluconeogenesis, right? So all the steroid therapies, epinephrine, high growth hormone, they all can cause the diabetes mellitus. Okay, now these are the acute complications. Now let's talk about the chronic complications, and chronic complications are because of two things. Okay, not two, but because of three things, you can say. Okay, first thing is the non-enzymatic glycation. Okay, every protein in your body, like we have discussed, the post translation modification, and one of them is the addition of glucose or other polysaccharide at the end of the protein, right? Which is known as the, remember the process name?
Glycosylation.
Glycosylation, right? And it is because of some enzyme. In the case of diabetes, in case of a chronic diabetes, when you have a high level of glucose, all these glucose will start binding to the proteins, right? And they causes the non-enzymatic glycation. That is the first thing. Second thing, because glucose is a osmotically active agent, it will do the water, it will cause a cell swelling, it will cause the other diseases. Second is the osmotic damage, and third is the oxidative damage. If you remember from the biochem lectures, okay, we have discussed how the glucose is converted to the sorbitol, right?
Yes.
Remember the sorbitol pathway, and when the glucose converted to the sorbitol, it will takes up all the NADPH, right?
Yeah.
And when the NADPH is lost, your body will become vulnerable to the reactive oxygen species. So three damages. One is the non-enzymatic glycation, second is the osmotic damage, and third is the oxidative damage. Okay, so for the non-enzymatic glycations, you have the small vessel disease first. Okay, and for the small vessel disease, there's a diffuse thickening of the basement membrane occur that can lead to the retinopathy. Okay, the vessels in your retina will become very weak, very fragile. They will rupture, they will cause the hemorrhage. Okay, you will have a weakening in the vessels because of the because of this glucose deposition and weakening of the vessels. It can cause some microaneurysms. Okay, and because of the hypoxia, because of of these aneurysms and this hemorrhage, the hypoxia will occur, and that can lead to the vessel proliferation. So this is known as the diabetic retinopathy. Okay, because of high glucose levels, okay, you can also get the glaucoma. Okay, you will get the high glucose levels in the neurons, which will draw up the water. Okay, and it will also cause the glycation of the proteins inside the neurons, so it can cause the neuropathies and then the nephropathy also. For the nephropathy, if you guys remember, you have the afferent arteriole and the efferent arteriole. Okay, non-enzymatic glycation will happens in the efferent arterioles. Okay, and the proteins will be started depositing on the vessel walls, and as a result, the lumen of the efferent arteriole will become very narrowed. Okay, and as a result, the pressure in the glomerulus will be increased, the filtration fraction will also increase, right? And these glycating products are also present in the afferent arterioles, which will be filtered. Okay, and they will start depositing in the nephrons to form the Kymel Wilson nodule, the KW nodules, remember?
Yeah.
Okay, so these these KW nodules are nothing but the advanced glycating products. Okay, and because of this loss of lumen size in the efferent arteriole, you are having a very high pressure in the glomerulus that can cause the nephropathy. Okay, you will have a progressive proteinuria also. Initially, it would be the albumin, then other proteins are also there. Okay, and that's why because of this lumen narrowing in the efferent arteriole, okay, if the renin is there, okay, so it will release the angiotensin 2. Angiotensin 2 will also cause the further constriction, right? So you need the ACE inhibitors or the ARBs to inhibit the renin so that the angiotensin 2 cannot vasoconstrict the efferent arterioles. And as a result, you will get a dilation, you will get the relief of pressure in the glomerulus. And that's why the ACE and ARBs are renoprotective. Okay. And like we have discussed, the diabetes mellitus is an important risk factor for the atherosclerosis. Okay. If this atherosclerosis happen in the kidney, it can lead to the chronic kidney disease also, right? For the large vessel atherosclerosis, you can have a coronary artery disease that can lead to the myocardial infarction and even the death of the patient, right? For the peripheral vascular occlusion, okay, that can lead to the gangrene formation or the limb loss. Okay, it can lead to the cerebrovascular diseases. It can lead to a stroke because of this atherosclerosis formation. Okay, the patient can get the stroke. Okay, and the most common cause of death in case of the complications is the myocardial infarction. Because of the large vessel atherosclerosis, the patient will eventually get the myocardial infarction, and that can lead to the death of the patient. Even in the patient with the chronic kidney disease, okay, they will die due to the myocardial infarction or other heart-related issues. Okay, so if the step one asks you what is the most common cause of the death, it is because of the myocardial infarction. Okay, 50% of the patients, okay, they develop the chronic kidney disease, and even in the chronic kidney disease, they will develop the cardiovascular complications and they die of it. Okay, so most common cause of death is the myocardial infarction. Second is the osmotic damage. Because the glucose is an osmotically active agent, it will draw the water along with it. Okay, it can lead to the neuropathies. Okay, and the distal part, because of this advanced glycating products, because of the osmotic damage and because of this oxidative damage, okay, the distal parts of the neuron will be affected first. Okay, because there will be the watershed areas. So what you will get is the motor and sensory in the glove and stocking distributions. Okay, you will get the glove and stocking neuropathies. Okay, you will get the autonomic degeneration. In the autonomic degeneration, you can either have a sympathetic degeneration or you can have a parasympathetic degeneration. If the parasympathetic degeneration occur, that can lead to the diabetic gastroparesis. Okay, if the sympathetic degeneration occur, that can lead to the diabetic diarrhea. Okay, very important. And yeah, because of the sorbitol accumulation in the lens, that can lead to the cataracts because of two things. First is the osmotic damage and second is the oxidative damage because of the sorbitol. Is that okay? The acute complications and the chronic complications?
I am having two questions.
Yes.
Why is angiotensin high in diabetes mellitus?
Why angiotensin is high?
Yeah.
See, how can I explain you this? You're having a loss of urine. You know, you're having a too much of the glucose. The osmolarity is very much high. Okay, you're having a loss of so much of the sodium along with the glucose, because you know that SGLT transporters are present in the urine. Sorry, in the PCT, right? SGLT2, right?
Yeah.
And if the glucose is not absorbing, then sodium won't be reabsorbed. Okay, so
Yeah.
both the glucose as well as the sodium will lost, right?
Yes.
And that's why you get this thing. Because of loss of sodium, because of the hyponatremia, you will get the activation of RAS.
Okay. Okay. And the second question is, simply if a patient is having chronic kidney disease, will the person also develop cardiovascular disease if the person is
Yes.
not having diabetes?
Yes, of course. 50% of the patient with a chronic kidney disease, they die of the cardiovascular complications.
Okay, so there's basically an association which is not well explained.
Yes. If you go back to the, I think, CVS part again, and you look under the heading for the angina, I think I have written it, that having a diabetes, having a chronic kidney disease, or having a atherosclerosis anywhere in the body, right? It is same as having the atherosclerosis in the coronary artery.
Okay.
Okay, it is same as having this. So, you know, all these patients having a diabetes, having a chronic kidney disease, or having atherosclerosis anywhere in the body, they die due to the infarction ultimately.
Okay. Got it. Thank you.
Dr. Chaudhary, could you explain the oxidative damage with the NADPH part again?
See, what happened? You have the glucose, right? And then you have the enzyme, which is known as the what was the name of the enzyme? I'm forgetting. The aldose reductase. Okay, you have the enzyme which is known as the aldose reductase. Now, this glucose, with the help of this enzyme, is converted into the sorbitol. Okay, now those cells which have the sorbitol dehydrogenase, they will convert the sorbitol into the fructose. Okay, and fructose can easily leave out of the cell, no damage will occur. Okay, but those cells which do not has the sorbitol dehydrogenase, ultimately what gonna happen? The glucose will be converted into the sorbitol by the action of enzyme aldose reductase, but sorbitol will be start accumulating inside the cell. And because the sorbitol is a osmotically active agent, this can lead to the osmotic damage. Now, during the reaction of conversion of glucose, into the sorbitol, it uses the NADPH. And you know that NADPH is required for the fighting with the reactive oxygen species. So if NADPH is depleted in converting the glucose to the sorbitol, okay, then no NADPH will be left for the reactive oxygen species, and you will get the damage from these species. Okay.
Okay, thank you. And then one more question. So in diabetes, we always when we think of diabetic paresis, we think of
Gastroparesis.
constipation. Yeah,
Yeah.
we think of constipation, but now you're mentioning it could be both diarrhea and constipation.
Yeah, exactly. It could be both diarrhea as well as a constipation. Depend whether you're having a sympathetic nervous system damage or you're having a parasympathetic nervous system damage. It depends.
Okay, okay. All right. Thank you.
I have a question.
Yeah, do ask.
I have a question.
Ask.
How does CKD causes cardiovascular? How does CKD
Why does
causes
CKD? Because
cardiovascular
first
disease?
thing is the uremia, of course. You're having so many toxins in your body, right? Lipids will be started accumulating in your body in a very high amount. Okay, and all these complications can ultimately lead to this. Uremia is most important, right? Because of the uremia you have. Wait a second, just let me turn off the microphone. Okay, yeah. So where were we? So because of the toxins which are accumulating inside your body, okay, you also have a platelet dysfunction, if you guys remember, right? You have a high BP also. Yes, you have a very high BP also in case of chronic kidney disease, and high BP is a very important risk factor for the atherosclerosis, if you remember, right? So because of high BP, because of uremia, because of certain toxins, high lipid levels, all of these things can lead to the cardiovascular complications. Is that okay? Please respond. Is that okay?
Okay.
Excuse me.
Yeah.
Yeah.
Ask.
Okay, I got the point.
Okay, so I have a question. Would you mind to please give mechanism of neuropathy, how it occurs in both autonomic and
See, for the neurons, every every neurotransmitter, every nutrition, okay, which is in the neuron, is all forming in the cell body, right? If I draw this,
yeah,
you have the cell body, okay, and then you have the axon part, right?
yeah,
Okay, and these cell bodies are lying in the ganglias, okay, and after the ganglias, there was a single neuron which run all the way to the limbs at the end of the fingers. Is that okay?
yeah,
So in a scenario where you have compromisation of the blood supply will be run in this direction, right?
yeah,
If your blood supply become compromised, then what's going to happen? All these nutritions which are forming inside these cell bodies, they will use the nutrition first, and then the remaining nutrition must be sent to the axons, right? If the blood supply is lost, then all of the nutrition, all of the remaining nutrition will be first utilized by the cell bodies, and no nutrition will be left to send to the neurons, so go to the axon part, right? So the first damage you will see is in the distal part only, which is are kind of a watershed areas. You can think of like them as a watershed areas. Okay, so in a scenario where develop the atherosclerosis or any loss of blood supply to the neurons, okay, this distal part will be affected first, because this distal part is dependent on the cell body for every nutrient. So if the cell body is not forming any nutrient, then how will it transfer the nutrient to this part, right? So that's why you have the loss of this sensory and the motor loss always in the glove and stocking distribution, because the most distal part of the axons lie in the hands and in the feet. Okay.
Is there something with the osmotic, like uh, glucose toxicity, like hyperosmotic things also with this?
Yeah, of course. This is a one thing. This is a one thing about the arteries which are supplying the neurons. You also have the oxidative damage in oxidative as well as the osmotic damage within the neurons also. And when the neurons die, the cell body can still use all of these nutrients, but it can it cannot would transfer these nutrients to the axon part. So ultimately, in every scenario, this distal part will die first, then the proximal part. So that's why we got a distal neuropathy first, then the proximal one. Okay.
And that's what it want to say, like gloves and stocking disturbance.
Yes, hands and feet will be affected first.
Okay, thank you.
Okay. Any more doubt?
No.
Okay, then we have discussed the complications, we have discussed symptoms. Now we need to discuss the diagnosis, how you can make the diagnosis. First is the HbA1c. Okay, what is this HbA1c? Does anyone know?
Glycated hemoglobin.
Yes. And what does this glycated hemoglobin represent? It represents the average blood glucose up to 3 months only, because the hemoglobin is present in the RBCs, right? And the RBCs has a lifespan of 120 days, which is 3 months approximately, right? So what's going to happen when the RBCs form? Just give me a second, guys. Okay. So what's going to happen when the RBCs are formed? Okay, first, so they will remain in the blood circulation for like 3 months or 4 months, right? And as long as they remain in the blood circulation, all of the glucose will be binding to the hemoglobin in the RBCs, and they will be converting it to the glycated hemoglobin. Okay, and when the cell dies, this glycated hemoglobin will also die along with it. Okay, so that's why this glycated hemoglobin represent only the 3 months period of the average blood glucose. Okay, and whenever you have a more than 6.5% of the glycated hemoglobin, that means it is a diagnosis of the diabetes mellitus. Okay, second thing will be the fasting this plasma glucose. If it is more than 126, that means it is a positive sign for the diabetes. Third thing would be the 2-hour oral glucose tolerance test. More than 200 will be suggestive of diabetes. Is that okay?
Yes.
Okay, so in the insulin deficiency state, or in case of an insulin insensitivity state, what's going to happen? The gluconeogenesis will be increased, the glycogenolysis will be increased. Okay, your tissues like the skeletal muscles, like the adipose tissue, they require the GLUT4, which is dependent upon the insulin. They cannot take up the glucose. As a result, you will get the hyperglycemia. Okay? And because of this hyperglycemia, you will have a high glucose in the urine. So you will have the hyperglycemia and the glycosuria. The plasma osmolality will be increased, and because of this increase in the plasma osmolality, you will have a increase in the thrust. You will have a osmotic diuresis, and because of that, you will have a loss of sodium and the potassium. RAS will be activated, no doubt, but it is kind of a failure thing. Still, it cannot prevent the loss of sodium as that much, because it is just a compensatory mechanism. It will try to get back the it will try to to keep the levels back to the normal, but it just a failed thing. Okay, nothing gonna happen. Then the hypovolemia will occur ultimately because of the osmotic diuresis. Okay, circulation failure ho jayega. Circulation failure will occur. Tissue perfusion will be decreased, and that can lead to the coma and the death. Okay, because the cell cannot use the glucose, they will try to use the proteins and the lipids. As a result, you will get the loss of muscle mass and the weight loss. You will get the high plasma free fatty acids. Okay, ketones will be formed only in case of diabetes type 1. You will get the scenario. Okay, you will get the ketonemia and the ketouria. You will get the vomiting, loss of sodium water furthermore happen because of the vomiting. Okay, you will lose electrolytes because of the vomiting, right? High anion cap metabolic acidosis will be created, and because of the high anion cap metabolic acidosis, you will get the respiratory alkalosis as a compensatory mechanism. So you will get the hyperventilation, and you will get the small respiration. You will have a very fruity odor also. Okay, then because of the circulatory failure, the hypoxia will occur. Okay, and because of the hypoxia, you will have a high serum lactate level. Okay, and these high serum lactate level will further promote the high anion gap metabolic acidosis. Okay, is this chart okay for everyone?
Yes.
Okay, then you need to know the complications happen to the fetus if the mother has a diabetes, uncontrolled type. One is the macrosomia. Macrosomia means weight, the birth weight more than 4 kg. Okay. Second thing is the hypertrophic cardiomyopathy. Remember. Okay.
Yeah.
And what other valve condition can happen because of diabetes mellitus? What other valvular conditions can happen because of diabetes mellitus?
We were getting transposition of great vessels. No?
We will get the
Transposition of great vessels.
yes, exactly. Do remember these things, okay? Transposition of great vessels will happen. Then polycythemia will happen because of the hypoxia. When the tissue gets the hypoxia, the compensatory mechanisms will be initiated, hyperventilation like. And second thing is to raise the RBC count so that more oxygen could be carried by the RBCs. Heart malfunction occurs because of this hyperosmolarity, loss of volume, and all these things, right? Neural tube defects can also happen. Okay. High glucose levels are a very important cause of neural tube defects. Okay. And most importantly, the fetus will get the transient hypoglycemia because of a chronically increased glucose in the fetal circulation. What's going to happen? The hyperplasia of the pancreatic beta cell occur in the fetus. So they will start releasing more insulin. Okay. So, and this insulin will be sufficient to counter the high glucose level in the fetus. Okay. But what's going to happen shortly after the birth? Okay, the glucose level will be revert back to the normal. Okay, shortly after the birth, but because of this high insulin level, they will further reduce the glucose and they can cause the hypoglycemia. And this is a transient hypoglycemia. After some time, the hyperplasia will be inhibited. The beta cell will revert back to the normal size, and as a result, the insulin will be normal again, and the patient will get the normal glucose level. Okay, so a very important thing, the fetus will get the transient hypoglycemia shortly after the birth. Okay, any doubt?
I have a question.
Yes.
Is there any reason of getting polycythemia in the kid?
Yeah, because of hypoxia.
Like why is diabetes causing hypoxia in the child?
Circulation failure.
Oh.
We've discussed that, I think.
Okay. Yeah.
Because of the hypovolemia, because of circulation failure, you will have the decreased tissue perfusion, hypoxia will occur, right?
Okay. Yeah. Thank you.
Dr. Chaudhary, one question. So
yeah, do ask.
In diabetes mellitus, you have increased breakdown of protein and increased breakdown of fats.
Yes.
But why is it that in type 2 diabetes, you won't have, you should have increased ketones in the type 2 diabetes as well, because technically...
No, in type 2 diabetes, you have the insulin, right? In type 2 diabetes, you have the insulin, which is sufficient to prevent these complications.
Okay.
But in type 1, you are just, you lost all of your insulin. Okay. No insulin will be there in case of type 1, but in case of type 2, you still have some insulin, which is working. Okay. So that's why you can, and that's why cell will get the enough of these glucose. Okay. The glucose will be inside the cell. They will be using it. Okay. And that's why you won't get that, the ketoacidosis or the weight loss much. Okay.
Okay, so in type 1, you get more weight loss, and in type 2, you
Yeah,
get less.
exactly. Because insulin is just completely absent in the body.
Okay, got it. Thank you.
Okay. Then you need to understand the difference between the type 1 and the type 2 diabetes mellitus. In case of type 1, it is an autoimmune condition. Yeah, someone is asking.
Yeah, sorry, I want to go back questions. Like there is like cardiomyopathy. Is it also because of hypoxia and tratalase of like transpositions of great vessels is also because of hypoxia, or is there some other mechanism how it's
The transposition of great vessels.
No, I mean, what is the reason of cardiomyopathy and cardiac problem because of in this DM? Like
I think it is because of this, this condition, because you're having a hyperosmotic state, first thing, in the baby, right? And second thing, the heart will try to, and second thing, you are having a loss of tissue perfusion, right? So what heart will do, it will try to compensate this effect. The hypoxia is occurring, so heart will try to pump more and more and more, right? And so you will get the hypertrophy eventually because of this more pumping. Okay.
Okay, thank you.
Because the workload on the heart is already very much increased because of increase in this osmotic gradient and all these things, you know, and because of this hypoxia, heart need to pump more blood, right? And in order to pump more blood, it require more musculature, right? So that might be the cause of this hypertrophy. Other causes are also there. I really don't know the specific cause, but it is one of them.
Malformations is heart malformations is also related with something like, can I get
They're all because of high glucose level. Glucose is required by the cell for the function, right? Because glucose is not available, many things can happen. Okay.
all together malnutrition.
Any more doubt?
Yeah, thank you.
Okay. Then the difference between the type 1 and the type 2 diabetes mellitus. For the type 1, it is an autoimmune condition, okay, where you have the destruction of the beta cells of the pancreas by the T cells. Very important. Okay. And you will have the you will have the T cell mediated destruction of the B cells. Okay. And you have the antibodies against the insulin. In case of type 1 diabetes mellitus, you have the lymphocytic infiltration and the lymphocytic mediated disruption of the beta cells, and you have the antibodies against the insulin. Very important in case of type 1 diabetes. Okay. In case of type 1 diabetes mellitus, it is an absolute deficiency of the insulin. Okay. So you require the insulin as a treatment. Okay. The age, it is generally happen less than 30 years. Okay. So whenever you encounter any patient who is having, who is a teenage patient, okay, or might be an infant, okay, or might be a young adult, it will always gonna be a case of type 1 diabetes mellitus. Very important. Whenever you read a question stem, and in the question stem, the age of the patient is below 30, which means it could be a patient of 7 years of age. It generally happen. Okay, very infants, a very small children's, who they can get a diabetes type 1. Okay, because of this autoimmune condition. So okay, so it is always gonna be a very young patient or a teen patient or a child for a type 1 diabetes, even a 4-year age. Okay. I see. I think 2 or 3 of the questions from the UL, they have mentioned the age of the patient for like 4 or 5 years only. Okay. So it is always going to be a type 1. Okay. Does it associate with the obesity? No. The patient will have a history of weight loss, not a weight gain in case of type 1 diabetes. Okay. Genetic predisposition is kind of 50% only. Okay. And it is kind of a polygenic. Okay. Both the environmental as well as the hereditary conditions will decide whether you get a type 1 diabetes or not. Okay. It is associated with the actually DR4 and DR3. 4 minus 3 you will get a type 1. So it is very kind of easy to remember. Actually DR4 and actually DR3. Okay, as you can see, because lymphocyte T cells are involved, that means MHC2 is involved. That's why. Okay, MHC2, CD4 cells are mainly involved in this scenario. Does you get the glucose intolerance? Well, of course, yes. You have a very high glucose level. That's why the glucose intolerance. Insulin sensitivity is very much high. It's just you're not having insulin at all. Okay. Ketoacidosis is very much common. Beta cell numbers will be decreasing. Serum insulin level will be very much low. Classical symptoms are very much common. Okay. And patient will fail to gain weight despite eating much. They will have a history of polyphagia. They will have a history of frequent urination. They have a frequent and they have a history of this frequent water intake. Okay, even though they're eating everything, a very high diet, despite of this, they're having a weight loss. Okay, this is a very important thing to consider. On the histology, when you do the biopsy of the pancreas, you will see the lymphocytic infiltration. Very important. And eventually, with the damage or the inflammation of these beta cells, ultimately you will also get a damage of these alpha cells. Okay, and when the damage of alpha cells occur, you can also become deficient of the glucagon. Okay, it is also very much important to note. Along with the beta cells, in the very later stages, you can also get a damage of these glucagons or the alpha cells. Okay, and you will get the hypoglycemia then profound. So that is the important thing to consider when you're giving the patient a therapy for the diabetes. Okay, so that they won't get the hypoglycemia. Okay, so most patients with the diabetes, they diagnosed before the age of 10. Okay, and the onset of the diabetes in the adolescence and the adulthood is very common. It is for a type 1. Okay, very important. And yeah, so weight loss is there in both the hyperthyroidism and in the type 1 diabetes. Weight loss is there. Okay, so you just need to look for the other symptoms also to diagnose it with the type 1 diabetes or to diagnose it with the hyperthyroidism, like the heat tolerance, sweating. Okay, other things are also considered. Then comes the type 2 diabetes mellitus. Okay, it is because of the insulin resistance, and the triglycerides level are directly responsible for the insulin resistance. Whenever you have a high triglyceride level, you will have a insulin resistance. Okay, very important. And initially, the pancreatic beta cells will try to compensate this effect. They will try to compensate it by increasing the insulin secretion, but ultimately they will be exhausted and you will have a low insulin in the blood. Okay, does insulin is necessary for the treatment? Yeah, sometimes, but it is because mainly the resistance is there, so you need to look for the other options also, other drugs also. Okay, and because some of the insulin is there, you won't get the diabetic ketoacidosis in case of type 2 diabetes mellitus, because some insulin is there, some cells are still responsive to the insulin, so they will take up the glucose and they will do their job. You won't get a diabetic ketoacidosis. The age of onset is more than 40 years. So whenever you get a patient who has a newly history of a new diagnosis of the diabetes more than at the age of 40 years, that means it is a case of type 2 diabetes. Whenever you encounter a patient in the step 1 who has a new diagnosis of the diabetes at a age more than 40 years, that means it is a type 2 diabetes. Okay, does it associate with the obesity? Of course, yes. Higher free fatty acids or higher triglyceride level you have in your blood, more are the resistance to the insulin. And for that, you always measure the visceral fat. Okay, you always measure the visceral fat for that. Okay, and to measure the visceral fat, you need to measure the waist circumference. Very important. Step 1 will ask you this. Okay, in order to get an idea of how much resistance this patient is having, you need to measure the waist of the circumference of the patient. Okay, does it associate with the HLA system? No. Glucose intolerance is kind of mild because some insulin is there. Sensitivity is very low. Ketoacidosis is very rare. Okay, beta cell number will be variable. Initially it will increase, then amyloidosis will happen, inflammation will happen, then they will decrease. Okay, serum insulin level initially increase, but after the exhaustion it will be decreased. Okay, symptoms of the classical polyuria, polydipsia won't be there or sometimes there, but you will get the metabolic syndrome with the type 2 diabetes. Very important, you will get the metabolic syndrome in the type 2 diabetes mellitus. And does anyone remember the features of a metabolic syndrome?
Hypertension, diabetes, and obesity, and hypercholesterolemia.
Hypo or hyper?
Hyper.
Hyper, yes. Low HDL, high LDL, high cholesterol. Okay, very important. Hypertension, atherosclerosis, or other disease also. These are the important things for the metabolic syndrome. On the histology, you will see the amyloidosis, and the amyloid is the islet amyloid peptide. Islet amyloid peptide. Okay, IAPP deposits, also known as the amylin. So step 1 can give you either the name amylin or they can give you the IAPP as the deposits in the amyloid. Okay, and what is the most common location for the amyloid deposition?
Kidney.
Yeah, not the organ, but within the tissue where?
Around blood vessels.
Blood vessels, around the blood vessels. Okay, please remember it. And that's why the blood vessels become very weak and fragile. Hemorrhage can happen. Okay. Okay, now let's discuss the diabetic ketoacidosis in which the insulin is completely absent. Okay, you will have a high ketone levels in the body. Okay, and that will cause the complications. Now, because and how will you get a diabetic ketoacidosis? So it would be a patient who is having a prolonged history of the diabetes. Okay, either they are still not diagnosed with the diabetes. Okay, or they're diagnosed and taking the therapy. If they're not diagnosed yet, then they will have an increasing level of glucose and increasing level of the ketones, and at some point they will start developing all these symptoms, and that would be the point when you diagnose the patient with the diabetes mellitus type 1. So most of the time when patients come to the department, they will having the symptoms of the diabetic ketoacidosis. And at that time, you know that the patient is having a type 1 diabetes mellitus. Second thing, whenever the patient get a acute stress, okay, like an infection, okay, in that case, excessive breakdown of the fat will occur. And in that scenario, you will get the symptoms of the diabetic ketoacidosis. Okay. So most of the time when you diagnose the patient with the type 1 diabetes mellitus, it would be the time when they present you with the diabetic ketoacidosis. Okay. And because I told you that insulin is responsible for the potassium influx in the cell, right? And because the insulin is not present in diabetic ketoacidosis and you're having a very high glucose level, okay, and high glucose levels are responsible for the efflux of the potassium. Okay, you wait for the renal section, we will discuss that later again. High glucose levels are responsible for the efflux of the potassium, and high insulin levels are responsible for the influx of the potassium. So because of low insulin and high glucose, you will get the high efflux of the potassium, first thing. Okay, because SGLT2 transporters are kind of inhibited now because of this high glucose load. Okay, sodium will be lost from sodium will be start losing in the urine. Okay, and not just because of SGLT, but because of this hyperosmolar state also. Okay, it will draw the sodium, whenever the water is kind of excreting out of the urine, it will always attract the sodium along with it. So you will get the low sodium levels. Okay, even though the serum values will show the high potassium level, okay, you are actually having a total loss of potassium. All of the potassium which is in the serum will be excreting out of the body, and all of the potassium which is in the cell, it will be effluxing out of the cell. Okay, so it will maintain the serum levels, or it can increase the serum level of the potassium, but ultimately the cell will be devoid of the potassium. So total potassium stores are divided. Okay. Okay, other thing, because of this lactic acidosis, and because of this the ketoacidosis, you will get the high H plus levels. Okay, you will have a because these keto acids are kind of external acids in your body, and the lactic acid again is an external acid in the body. Both of them will be releasing the H plus ions. These H plus ions will combine with the bicarbonate to form the H2CO3, and that will decreases the value of free bicarbonate. So in the serum, you will see the low levels of bicarbonate. Even though in the kidney, you are increasing the reabsorption of the bicarbonate. Very important, in the kidney, you are increasing the reabsorption of the bicarbonate, but total bicarbonate in the serum will be low. Very important. Okay. In the urine and in the serum also, you will have a high ketone levels. Okay. You will have either the normal or the increased potassium levels, but a depleted intercellular potassium ions because of this transcellular shift. Okay, because of the osmotic diuresis, you will have a loss of potassium as well as loss of sodium also. Okay, very important. And secondly, because you have this hyperosmolar state in the body. Because of this hyperosmolar state, all of the water which is inside the cell, it will be start coming out of the cell. So it will cause a dilutional hyponatremia. Very important. Dilutional hyponatremia is the one thing. Loss of sodium is the second thing. Okay. Both of these things can cause the hyponatremia ultimately in case of diabetic ketoacidosis. What symptoms you will get? You will get the delirium, psychosis. Okay, you will get like a small respiration, which is the rapid deep breathing. Why rapid deep breathing? Because you're hyperventilating now because of the ketoacidosis, acidic thing. Okay, so respiratory alkalosis will take place, and that can lead to the small respiration, pain, nausea, vomiting. Generally, these are the presentation. Whenever the patient with diabetes type 1 present you, they will always present you with these things: abdominal pain, nausea, and vomiting. And when you run the test for the diabetes, they will come out to be positive, and that's how you know the patient is having a type 1 diabetes mellitus. Dehydration will be there, and the fruity odor will also be there. Okay, so is that okay for the diabetic ketoacidosis?
Yeah, I have one question.
Yes.
What's the reason of those GI symptoms in diabetic ketoacidosis, or they are just generic symptoms?
Yes, generic symptoms.
Okay, thank you.
In diabetes ketoacidosis, you have dilutional hyponatremia, and we have also lost sodium as well.
Yes.
So actually, I'm not able to understand the difference between two. We are losing sodium, that we have hyponatremia. How are we losing sodium?
We are losing sodium because of this osmotic diuresis. Whenever you have a high flow rate, okay, you have the loss of sodium, you have the loss of potassium. Okay, you're also having a loss of this SGLT2s, right? Because SGLT2 are responsible for the reabsorption of the sodium and the glucose. Okay, if the glucose is losing, then sodium along with the glucose will also be losing from the body, right? So these two things are for the loss of the sodium, and then all of the water which is inside the cell, it will be coming out, okay, and it will be causing the dilution hyponatremia also. So both of these things ultimately causing the low sodium levels.
Isn't wouldn't be the homeostatic mechanism turned on, and because of loss of volume, the RAS
Of
system will.
course, yeah, you will have the activation of the RAS system, no doubt.
Yeah.
That will further promote the loss of potassium again. But all of these are the compensatory mechanism. Okay, all of them are the compensatory mechanism. They will try to get back the normal levels, but they actually fail to do so. They can never be, they can never be so much activated to cause the normal levels. Okay, they will just try to compensate them, but not always they can achieve it. Okay, because if you do not have these compensatory mechanisms, then if this is a normal levels, okay, then without a compensatory mechanism you will be having at you will be at these levels. But because the compensatory mechanisms are there, you will found yourself at these levels, but it's still low, as you can see, than the normal levels, right?
Yeah, right. And how would we differentiate the hyponatremia of these two types?
I mean, there is no way to differentiate. Step one won't ask you, don't worry.
Okay, it has to do something with osmolarity kind of thing.
Sorry, I didn't
Checking the
understand.
osmolarity.
Both things are there. See, at the same time, both things are happening. Then how can you differentiate? I mean, I don't understand.
Okay,
I mean,
okay.
why do
No,
you need to differentiate?
okay, actually, there are certain causes of hyponatremia. Like there is dilutional hyponatremia, there is hypovolumic hyponatremia, there is. So to differentiate between these types, I think we calculate osmolarity.
Yeah, of course.
So, okay, I think this thing has nothing to do with this topic.
Yeah, I think you're talking about the SIADH and diabetes insipidus, maybe. These causes of hyponatremia and hyponatremia, right?
Yeah, that is more significant over there. Thank you.
Okay. But just give me a second, guys. I have to attend an important call. Okay. Yeah. So. So, any doubts so far again?
No.
Okay. Then comes the complications. Already from the the microbiology that it can cause a life-threatening mucormycosis, the diabetic ketoacidosis only. Okay. Cerebral edema can happen, right, because of this hyperosmolarity conditions. Okay, the cardiac arrhythmias can occur, right, and heart failure can also occur. Okay, treatment, it includes the IV fluids, because you're having loss of total fluid from the body. You're having this the dehydration because of the polyuria. Okay, so you need to give the patient IV fluids. Because you're having a loss of potassium, loss of sodium, you need to give the saline. A hyperosmotic saline would be good. Okay, uh, then you also need to give the patient insulin, okay, and the potassium to replace the depleted intercellular stores. Very important. Potassium, saline, and the insulin. Okay, and That would be all about it. Okay, then comes the hyperosmolar hyperglycemic state. See, insulin is present. Okay, cells can still take some amount of glucose. That's why ketones won't be present. And because the ketones are absent, all of these symptoms, the abdominal pain, nausea, vomiting, they won't be happening, right? And that's why it is very hard to diagnose these patients, because they are generally asymptomatic and they will just die without even, without even getting diagnosed. Okay, so a very dangerous disease, hyperosmolar hyperglycemic state, very important to diagnose it. Okay, because of the excessive osmotic diuresis, you have the dehydration, you have the increased serum osmolarity. Okay, and you have the hyperosmolar hyperglycemic state. Okay, it is only seen in the elderly with the type 2 diabetes mellitus, which are limited ability to drink. Symptoms include a thirst, polyuria, lethargy, focal neurologic deficits because of this neurologic dysfunctions. Seizures can also happen because of the hyponatremia thing. Okay, for the labs, you will get the hyperglycemia, and note that fact: the hyperglycemia is more than 600. Very important. In case of this diabetic ketoacidosis, hyperglycemia can never reach 600. It is always less than that. Okay, you will get the hyperglycemia in both, but the hyperglycemia in this hyperosmolar hyperglycemic state is more than 600. Very specific for it. Okay, so whenever you encounter a patient having a glucose level more than 600, that means the patient will be having a type 2 diabetes, not a type 1. Serum osmolarity will be more than 320. pH is normal because there is no acidosis, there is no lactic acidosis. No ketones will be there, right? Normal or increased, this potassium will be there, or a total loss of potassium will be there. We will get the dilutional hyponatremia again. Okay, it can progress to the coma and death if left untreated, which happens most of the time. Okay. Treatment includes again the IV fluids, insulin, and the potassium. So whenever you encounter a case of the diabetes type 1, okay, you do not need to check the foot of the patient. Okay, because you know that the patient is recently started having this diabetes. Okay, because if you do not give the treatment for the diabetes at then at a very early stage, they will develop the diabetic ketoacidosis. So whenever you encounter a patient with a diabetes type 1 who recently diagnosed with a type 1 diabetes mellitus, you do not need to check for the foot of the patient now. Okay, you need to check after 7 or 8 years later, and then regularly. But if you recently diagnosed a patient with a type 2 diabetes mellitus, then you are not sure for how long the patient might be having a diabetes. Okay, so as soon as you diagnose the patient with the type 2 diabetes mellitus, you also need to begin the foot examination, because a diabetic foot can occur in case of diabetes, right? So you need to do the regular examination of the foot of a type 2 diabetes mellitus patient as soon as you diagnose them, because you can never be sure for how long these guys must be having this the type 2 diabetes, because as you can see, all of them are very kind of asymptomatic, not unlike the diabetic ketoacidosis. Is that okay?
Yes.
Good. Okay, then comes the Cushing syndrome. Okay, for the Cushing syndrome, you are having a very high level of this steroid, the cortisol in the body. Okay, so first you need to know the etiology or the cause of the Cushing syndrome. It could be due to the exogenous steroids, which is the most common type. If you take the exogenous steroid, the ACTS will be suppressed, and as a result, you will get a bilateral adrenal atrophy, which is the most common type. Okay, in case of a primary adrenal hyperplasia or a adenoma, okay, hyperplasia of the side of the gland, okay, which is a tumor, will be increased. Okay, size of the tumor will be increased, and the opposite gland, which is normal, okay, atrophy of the gland will happen. Very important. In case of a primary adrenal adenoma or hyperplasia or carcinoma, okay, atrophy of the uninvolved gland will happen. It could be due to the ACTS secreting adenomas. Okay, in case of pituitary, it would be the Cushing's disease. Okay, very important. It is not a Cushing syndrome if it is released by the this pituitary. Okay, if the if the symptom if the syndrome occur because of the pituitary involvement, that means it is because of the Cushing's disease, not the Cushing syndrome. Okay, then second one is the paraneoplastic ACTS secretion, okay, which happens mostly in the small cell lung cancer, okay, and the carcinoid tumors. Okay, in that case, we will get the bilateral adrenal hyperplasia. Okay, and the one way to differentiate between the Cushing's disease and the paraneoplastic ACTH secretion is to give the patient high dose of glucocorticoids. If after giving high dose of glucocorticoids, ACTH is suppressed, that means it is because of the Cushing disease. If even after giving the patient high dose of these steroids, okay, the ACTH is not suppressed, that means it is because of the cancers, other areas like small cell lung cancer or the carcinoids. Is that okay? The causes and the differentiation?
Yeah.
Okay, then comes the findings. Findings, first you will have a high cholesterol. You will have an increased urinary free this cortisol. You will have the skin changes because the steroids, they ultimately decreases the collagen synthesis and they increases the collagen cross linking. So you will get the thinning of the skin. You will get the striae formation, as you can see in the figure A. Okay, you will get the hypertension. Okay, you will get the immunosuppression because what they will cause a demigration of the demigration of the neutrophils will occur. Okay, and the lymphopenia will always occur because of the cortisol, because they can cause apoptosis of the lymphocytes. So anti-inflammatory, and they also inhibit the prostaglandin pathway and the leukotriene pathway. Okay, then neoplasm, which is not a finding but a cause. Okay, the growth retardation can occur in the children. Okay, high glucose level will be seen. So you will diagnose a patient with the diabetes, and then you come to know that the patient is not having a primary diabetes but a Cushing syndrome. Okay, you will also have the amenorrhea because of the steroids. They will suppress the GnRH, FSH, LH. You will have the amenorrhea. Moon faces because of the edema will happen. Okay, buffalo hump. See, very important. What happens is the cortisol actually causes the the displacement of the fat from the periphery to the central part. Okay, cortisol will causes the redistribution of the fat from the periphery to the central part, and as a result, you will get the central obesity and peripheral wasting. You will get the central obesity and the peripheral wasting. So the signs of the central obesity include some moon faces. Okay, as you can see in the figure B, you will see the buffalo hump because of this fat deposition. Okay, you will get that truncal obesity also, right? And on the periphery, you will see the muscle wasting. Okay, you will see the muscle weakness. You will see the atrophy of the muscles. Okay, and it is without pain, just the weakness and the atrophy will be seen. The CK levels are absolutely normal. Only in case of hypothyroidism, you will have the high CK levels. Okay, and the patients will also get the osteoporosis. Okay, because they can directly activate the osteoclast and inhibit the osteoblast. Okay, you will get the hirsutism. Okay, and yeah, that would be all. Any doubt on the findings?
No, thank you.
Okay, then comes the diagnosis. First, you need to first you need to check for the ACTH levels. If the ACTH levels are raised or fall. If the ACTH levels are raised, then it could be either due to the ACTH secreting pituitary tumor, or it could be due to any other, the paraneoplastic tumors. Okay, if the ACTH levels are suppressed, that means it could be either due to the exogenous steroids, or it could be either due to the carcinoma of the adrenal glands. Okay, then for the low ACTH, you will do the CT or imaging things. Okay, if the hyperplasia was there, that means it is a cancer. If the atrophy is there, that means it is a exogenous cause, right? For the high ACTH, okay, you will first do the dexamethasone suppressing test. Okay, if after the dexamethasone suppressing test, small dose, low dose, okay, if it inhibits if it inhibits my ACTH, that means it is a normal condition. Nothing is happened. If after giving the low dose with dexamethasone, suppression of ACTH is not happened, okay, then it means it is a ACTH dependent Cushing syndrome. Okay, and in that case, you need to do the high dose dexamethasone suppressing test. Okay, for the high dose dexamethasone suppressing test, if after giving the dexamethasone ACTH is suppressed, that means it is a Cushing disease. Okay, if the ACTH is not suppressed, that means it is a ectopic secretion or a paraneoplastic secretion of the ACTH. Then in that case, you will do the MRI or the CT scan of the chest, abdomen, or pelvis. Okay, for the chest, it would be due to the bronchial cancer or the small cell lung cancer, right? Similarly, you can do the MRI of the pituitary also. So this is how you diagnose or and differentiate different causes of the Cushing syndrome. Is that okay?
Yes.
Okay. Then comes the Nelson syndrome. What happens? Let's suppose there is a ACTS secreting pituitary adenoma. Okay, and for that PCTS secreting this pituitary adenoma, you did the bilateral adenectomy. Okay, now what gonna happen? Because of this bilateral adenectomy, the negative feedback is now lost. Okay, and because the negative feedback is now lost, you will see a very heightened increase in the concentration of ACTH, and that can lead to the hyperpigmentation, that can cause the hyperplasia of the tumor again, and that can cause the mass effects. Okay, and that can compress your this optic chiasm, can cause the bitemporal hemianopia. Okay, that can cause the headache. Okay, so for any pituitary tumor, if you do the bilateral adenectomy, then you can have a even worsening of the pituitary tumor, right? And this is known as the Nelson syndrome. So what is the treatment? Treatment is to remove the tumor. Okay, and the radiations for the residual tumor. Is that okay?
Yeah.
Okay, so we are done with the Cushing's syndrome and the Cushing disease. I think we should wind up here for now.
Yes, we should.
Yes.
Okay.
Yeah.
Tomorrow we will finish the endocrine and we will start with the GIT. Okay, tomorrow.
Okay.
So much.
Okay.
Thank you.
Thank you,
Thank you
everyone.
so much.
Thank you. Thank you.
Thank you.
Thank you.